On behalf of the Indian Society of Medical and Pediatric Oncology, AstraZeneca, and Kavina Creations, I welcome you to the ONCO Summit 2024, Chapter 1, Hepatocellular Carcinoma. It gives me great pleasure to introduce Dr. Maheboob Basade, President of ISMPO and Professor, Department of Medical Oncology, Breach Candy Hospital and Jaslok Hospital, Mumbai, to please give the welcome and introduction. Over to you, sir.
Thank you, Kashish, and welcome everybody on behalf of ISMPO. As you are aware that Indian Society of Medical and Pediatric Oncology has a lot of new initiatives in academics with the help of the industry. And I'm very happy and to share you the first one with the help with the AstraZeneca. So AstraZeneca is doing wonderful academic grants providing us so that we can achieve and share the knowledge of ours among each other, as well as we can also have some international speaker as a guest faculty. I welcome Dr. Choo Su Pin and my program directors for today's program, Dr. Vamshi Krishna from the Hyderabad and Dr. Viraj Lavingia from the Ahmedabad. So both of you would take over from me once I finish from here, and you can conduct the program. So today's program is going to be on the hepatocellular carcinoma, and I'm happy to introduce, and it's my pleasure to introduce Dr. Choo Su Pin, who is a senior medical oncologist currently working in Singapore in the Curie Hospital. She has a lot of interest and she has done a lot of research in all GI cancers, typically colorectal cancer, small bowel, and the hepatobiliary and pancreatic cancer. She has got a pivotal role to be played in the National Cancer Center Singapore, and she is deputy head of the medical oncology and director of the GI cancer department program. So welcome, Dr. Choo, on behalf of ISMPO, and I will hand over to Viraj and Vamshi Krishna to conduct the program further. Thank you. And big thank you to AstraZeneca. So Viraj, you can take over. Vamshi, I can't see.
Yeah. So good evening, everyone. So thank you for setting up stage, Maheboob sir. Without wasting time, I think so we'll start off with a lecture today by Dr. Choo. She is going to talk about HCC and role of systemic therapy there. And then we have crafted a program for about 1.5 hours to 2 hours, mainly for students, which will include about 5 cases. Each center, Ahmedabad, Hyderabad, Delhi has 2 centers and 1 Tata Memorial. So 5 centers will present a short case, and we will discuss almost everything possible for HCC, starting from screening to local regional therapies, the fight between STER and SBRT, immunotherapy, and then we'll kind of give a short summary to students that what is it that they need to know for HCC in today's world in 2024. So that will be the program for today, for the whole evening. And we will start with a session and talk by Dr. Choo. Ma'am, the floor is all yours.
Okay, thank you very much, Dr. Krishna and Viraj, and Dr. Basade for the warm welcome. And thank you, AstraZeneca, for arranging this, and ISOP for inviting me here to speak. And it's quite amazing having to share this across India, right? This is across India, right? It's that's what technology allows us to do, which is fantastic. So without further ado, I'll just get into the point that I'm supposed to share with you guys today. And the topic I was given was looking at immuno-oncology as the new paradigm shift in management of unresectable HCC. So, sorry, there's a missing C, I don't know why. These are my disclosures. And I'll go straight into it because today my focus will just be on systemic therapy in advanced HCC. And I'm not going to talk about adjuvant therapy at all because I only have half an hour. But what is very clear in the BCLC-C 2022 update is that now we have a lot more treatment options in the advanced stages with very effective systemic therapies. And now the difference between BCLC pre-2022 and the current BCLC treatment algorithm is that we do have systemic therapy extending into the BCLC-B stages as well, in particular those in the intermediate stage that we deem not suitable for local regional therapies. So I will just touch about intermediate HCC first. We know that they are a very heterogeneous group with very different outcomes. As you look in the pictogram here, all these would be classified as intermediate HCC based on the BCLC staging. However, you can see that the burden of disease across from the bits in green, which have minimal disease, to the section in red and yellow, but especially the yellow, which do really particularly badly because they have usually what we call more than 7, beyond the 7, up to 7 criteria, and have a bilobal multifocal disease. And this was started by Belondi, who modified the classification of intermediate based on the prognostic outcomes, and then was further fine-tuned by Dr. Kudo in the what we call the Kinky criteria that split the Bs into B1, B2, and B3s. Okay. So you can see if you split them up into this subclassification, the survival curves are quite different. And I think it's very important in the intermediate stage to determine what are our goals of treatment. In the past, every time we see an intermediate HCC, especially the more advanced multifocal disease, we're always talking about palliation. But I think in this current day and age with such good multimodality therapies as well as systemic therapies, we need to consider cure as an option in some of these patients. So what is the ideal taste candidate? That can be argued, but generally the ideal tasteable HCC will be the ones with small tumor, less than 5 cm, low volume disease, less than 5 lesions, no vascular invasion, Charles-Pugh score A, well or moderately differentiated in a fit patient, like the pictures here. And what would be a less ideal candidate, where we know the outcomes are not so good, would be HCCs that are large, more than 7 cm, more than 7 lesions, if there's portal vein thrombosis or invasion, the LB score is more than 2 or more, poorer ECOG, and poorly differentiated histologically. So the classification of this out of 7 criteria, I think Dr. Kudo has done a lot of work on this, and you can see that when you taste the patients who fit into the out of 7 criteria, they result in poorer liver function. So this was a paper we came up with some years back in 2020, led by Dr. Kudo, looking at changing the treatment of intermediate stage. At that time, lenvatinib had come into the market and was a very effective systemic TKI. So our argument then was that not all intermediate HCCs should undergo TACE, because if we are a bit more selective in who should get TACE, we'll get better outcomes. And the concept of a TACE unsuitable HCC was born, at that time we determined it as those who are unlikely to respond to TACE, especially those who have confluent multinodular disease. The infiltrative type HCC in particular don't do well with TACE, or if patients with sarcomatous or poorly differentiated histology. And patients who are also not suitable will be those who are likely to have TACE failure if they have more than 7 up to 7 criteria out, what nodules, what we call, or they have likely to have liver dysfunction after a TACE and from an A become a B or even a C. But with more years of research after that, the guidelines have become a bit more fine-tuned, and both ASLD and ILCA have their new guidelines on what's termed TACE unsuitable, and ASLD includes marked high AFP levels as TACE unsuitable. ILCA is a little bit different as well, but these are just guidelines, and I think it's still individualized to the patient and to each center's practice. With all these systemic therapies that we have in the advanced setting, and this is just a snapshot of all the many TKIs and immunotherapy agents and the anti-VEGF monoclonal antibodies that we have in our arsenal of our war chest to treat liver cancers. We can say that in general, with the combination in the advanced setting of IO or IOTK and treatments, we are achieving median OS of up to 23.7 months, as seen in the more recent combination trials. Median progression-free survival is up to about 9 months, and response rates of about 30% or so. Okay, and we are seeing with the immunotherapy agents very durable responses as long as up to 30 months with the latest EPNIVO study. In the intermediate setting, what are we expecting with TACE, if that has always been the standard treatment, and it still remains a standard treatment in the BCLC-B setting? Your median OS is about 19 months. So it's not direct comparison, but if you look at your advanced HCC setting, you expect a poorer outcome, but we are hitting similar or even better survival outcomes with the systemic therapies in the advanced setting compared to the TACE in the intermediate setting. But of course, these are based on older studies and the era of before immunotherapy. Okay. Is there any data for what we use in the first-line setting, advanced setting, which is atezo-bev in the BCLC-B stage? There is a subgroup analysis from the INBRAVE 150 trial. And you can see here that in the BCLC-B setting, in the not a large number of patients, about 73 patients, the median OS was 25.8 months, and the PFS was very encouraging, 12.6 months. And you can see the response rates were as high as 43% if you use RECIST 1.1 in this subgroup analysis. And many of these intermediate BCLC-B patients had prior local regional therapy and it failed, and thus were enrolled into this study. So besides TACE in the immune setting, there's been obviously trying to improve. We know TACE has its limitations, and we've been trying to improve the outcomes of TACE by combining it with systemic therapy. And the most studies have been done with sorafenib. Sorry, I go back up. Yeah. And really none of the studies have been practice changing. They've been including the SPACE, the global study that was really hard to do. And basically across the board, nothing has been shown to be better than TACE alone or even sorafenib alone. The TACTICS trial was the only one that showed PFS benefit. That was Dr. Kudo's study, but that's the way he determined progression was a little different, and I don't have time to go into that. But this slide just wants me, my point is to lead you into what we have now that we are beyond the sorafenib era, right? What else can we combine with TACE, and is there any rationale rather than just combining for the sake of combining? And we know that anti-VEGF and local regional therapy does have an impact on the tumor microenvironment, immune microenvironment, and maybe have immunomodulatory effects like priming the T cells and activating T cells. And if we combine these therapies with the checkpoint blockers, perhaps we can have synergistic, if not additive effects. Okay, and that's led to the EMERALD-1 trial. This was a randomized controlled trial in the intermediate HCC, global study, double-blind placebo-controlled. Patients in this study were those who are not amenable to cure and who had no extrahepatic disease, and patients with Child-Pugh A up to B7 were allowed into this study. And this patient also included those with macrovascular invasion, which is VP1 or 2. Okay, patients went through a mandatory upper GI endoscopy at least 6 months prior to randomization. And then they randomized to receive either TACE alone with placebo, which is arm C, that's the control arm, or TACE plus durvalumab followed by durvalumab, or TACE plus durvalumab followed by durvalumab and bevacizumab. The primary endpoint was reached in this study, which was progression-free survival of arm B compared to arm A, which is the durva bev TACE arm compared to the TACE alone arm. And the durva plus bev plus TACE was better than TACE alone in terms of PFS, almost double, 15 months compared to 8.2 months, with a hazard ratio of 0.77. Okay, there was also a secondary endpoint looking at arm A versus arm C, and we still don't have the OS data from this study. Just to show you the study schema, so how the therapies were sequenced, you can see that during the TACE period, whether it was the arm A or arm B, it was just durva every 4 weeks with TACE. Patients were allowed to receive up to TACE 4 times, but within a 16-week period. And in this study, about 60% of patients received about 1 to 2 TACE in all arms. Okay. After this 16-week period, and patients were then continued, depending on which arm they were, on durva or durva plus bev, which is the arm B, or just the placebo. So these are the 3 arms compared side in this trial. About half of patients came from Asia, and then if you include Japan, that will be just over half. Physicians were allowed to use either that beats TACE or conventional TACE, but majority, about 60% of patients had conventional TACE, and about a third were Hep B positive HCCs, whilst about 20% or so were Hep C. And non-viral made up the rest. About over half were BCLC-B. And if you look at the tumor burden within up to 7 criteria, or beyond up to 7 criteria, is almost half, but just about over half, a little bit more beyond the up to 7 criteria. Okay. Were there subgroups that particularly benefited more than others? I think the PFS benefit was generally seen across all subgroups, including the within up to 7 and beyond up to 7 criteria, because there was, whether or not there were differences in outcomes between these two subgroups that seemed to benefit across the board. Response-wise, the durva and TACE arm and the durva plus bev and TACE arm had responses of over 40% compared to just 29% in the TACE alone arm. So that better objective responses when you add IO to TACE. In the secondary analysis that looked at the durva alone plus TACE versus the TACE arm, there was really no improvement in PFS. So there's something about the adding of bevacizumab that led to the improvement in progression-free survival that was not seen in the durva alone arm. In terms of safety for the EMERALD-1 study, about more grade 3 or 4 toxicities were seen in the bevacizumab durva arm B, about 45%. And you have to note that this is almost double that of the other 2 arms. In terms of serious outcomes like death, the durva but TACE arm was 10%. Okay, in both the A and B, whilst there's only 5% in the TACE alone arm. In terms of AEs leading to discontinuation, also again, when you had the added durva plus bev, this was much higher, 24% compared to 12% with just durva alone, or TACE alone, which is just 7%. What the common AEs, largely due to the bev, hypertension and proteinuria, and the concern about, obviously, always with bevacizumab about hemorrhage, and don't forget these patients all had mandatory endoscopies. We still had esophageal variceal hemorrhage rate of 2.6%. So while we wait for the overall survival data from the Emerald-1 study, there are still many ongoing trials that would read out in time. In Emerald-3, they're also adding doing the strike regimen with TACE and the strike regimen plus lenvatinib with TACE. And there's also the LEAP, TACE, TALENT TACE, all using TACE plus some combination of IO compared to TACE alone. There are also two interesting studies in the intermediate space that was going to look at systemic therapy compared to TACE. And one is the ABC. Just maybe we don't even need local regional TACE because we've been using TACE for so many years because we had no other better treatment. Maybe these intermediate stage patients just need systemic therapy. These trials hopefully will give us clearer answers in the future. So I would say that in the intermediate HCC, we have to be more selective in TACing in 2024. In the past, we used to TACE, and then when TACE didn't seem to work, then we'll refer, well, at least my gastroenterology or hepatology colleagues will refer to the MET ONCO after they failed TACE, and then patients by then will often have significant liver dysfunction. And then we'll look at them and say, what can I do? Right? And most of our patients end up with best supportive care. So in 2024, I think we need to be more cognizant of what's TACE unsuitable and be more selective in TACing patients, especially when we have such good systemic therapies available. I would say that if you're TACE unsuitable, you should give systemic therapy first. And then in selective cases, TACE can still play a role, but you add the TACE later on. Let's say they have very large multifocal disease. Perhaps when you have some systemic control and you want better local control, TACE can be thrown in along the way. Of course, if they are TACE suitable, standard of care is still TACE. However, I think we are more eager to switch to systemic therapies once TACE fails rather than TACing indefinitely. I think our goal in treating these patients is really to maintain their liver function so that they have the chance to receive as many treatment options as possible, because we do have more treatment options than we ever did from 2 decades ago. We also have to be mindful of maintaining quality of life, and sometimes in this group of patients, we can aim for cure. So I'm just going to run through the advanced setting. What are the randomized controlled trials? There are at least 3 front runners now, and how do we choose? I don't have the answer. There are many considerations to factor in each practice of ours, and I'll be interested to hear what you guys are doing and learn from you too. But I'll just go through the data as it is. I'm not going to go through each trial one by one because we've all seen it many times. But I love to put the trials side by side, which of course you shouldn't be doing cross-trial comparison. But, it gives us an overall picture of where these trials were conducted and any differences between the trials. So in red is Embrave 150. This is the only first-line combination that's in our cancer drug list in Singapore. That's why it's in red. However, the strike regimen is also approved in Singapore for use in the first-line setting. Ipilimumab plus nivolumab is not approved in first-line settings, approved in the second-line setting and beyond, but it's also available in Singapore. There are 2 China options as well, sintilimab and other camrelizumab and so on, but we don't have those drugs available in our setting at the moment. So I just focus on Himalaya, Checkmate 90W, and Embrave 150, and they're all randomized global phase 3 trials with a similar proportion of Asia Pacific patients in all these trials, about 40%. Okay, and as expected, about a third, though slightly more, in Embrave had about almost 50% in Embrave had B viral or had B carriers, whilst the others were about 30%. In terms of extrahepatic disease, across about, it's very similar, maybe more advanced disease in the IMBRAVE study. This is cross-trial comparison, so please a lot of caveats. But generally, most had prior anti-cancer therapy of some form, usually local regional therapies. And in all the studies here, if you look at the subsequent anti-cancer therapy, including IO, especially in looking at the sorafenib treated arm, about half went on to receive some form of systemic therapy. The difference between Himalaya and Checkmate 90W with IMBRAVE is that the first two studies excluded patients with main portal vein thrombosis. I guess they wanted a fitter group of patients to test the combination. Whereas IMBRAVE 150 allowed main PVT patients, and about a third of them had main portal vein thrombosis. So this I remind you that the designs of the three key RCTs in first line advanced HCC. This the IMBRAVE 150 primary endpoint was co-primary endpoint of OS as well as PFS, and as because BEV was used in such high doses of 50 milligrams per kg, there was mandatory OGD for all patients. Then Himalaya was the second study that came about, and this study did not require OGD and did excluded patients with main portal vein thrombosis. And this study, the main primary endpoint was just OS. And remember that tremelimumab in this study, they had multiple arms. I won't go into details, but the T25 plus D arm was closed prematurely because of toxicity and didn't show any added benefit. So it's a single priming dose of tremelimumab and then followed by durva every 4 weeks. Whilst 90W is used the ipilimumab nivo, and ipilimumab was 4 cycles at 3 mg per kg, right? Every 3 weekly, and then with the nivolumab 1 milligram per kg every 3 weekly, up to 4 cycles, and then after that the nivo was just 480 milligrams, very high dose, but the flat dosing at 4 weekly. And the key thing about 90W that's different from the other studies is that lenvatinib was allowed in the control arm, and majority, 85% of patients in the control arm received lenvatinib. Again, this study's primary endpoint is just OS. Okay, so and we know lenvatinib has a much higher response rate compared to sorafenib, even though the reflect trial was just to show non-inferiority. So here we have the study side by side. You can just say that I think so far the most impressive in terms of median OS is the 90W 23.7 months, whilst the Himalaya of 16 months, whilst Atezolbev of 19 months. But generally you're hitting this 20-month mark. When I talk to patients now, I don't say, oh, your median survival is only 10 months, which was what SHARP was, the sorafenib study. Now we can talk about 20 months sort of survival. And then in responses, about 30%, especially with the 90W and Atezolbev. And also very long. What is very impressive is the duration of responses. And in particular, 90W, the median duration of response was like 30 months. Okay. So even if you look at the China studies, you are seeing very similar results across the board. So these are the OS curves, because that's what's led to their approval. Atezolbev, you can see at 18-month mark, 52% are still alive. And then Stride has updated their 4-year OS, where 1/4 of patients are alive at 4 years. If you told me this 15 years ago, I'll be like, wow, okay. And then if you look at the Nivo data, and they have a 36-month rate, about 38% are still alive. Okay. Are there subgroups which benefit more or less from one, so they can decide whether, if all these treatments are available to us in front of us, will it help us decide whether we give Atezolbev versus the IO combination? I think the data is not clear because these are subgroup analysis. You can see EP-Nivos and Atezo-Bev. Basically, you're seeing benefit across the board. And I think it's a little hard to say that there's some discussion that Hep B may have better responses to IO drugs, but I think the data is a bit conflicting in if you look into the literature. Okay, what we know is that responses does correlate with better outcomes in these combinations. You can see the PEth, CR, patients doing super well on the Atezo-Bev, and then similarly in the Himalaya, those who have disease control versus those who don't have disease control, the curves split very nicely, and similarly in the Checkmate study. How about toxicities? I think the Himbrave has, as mentioned, the main concern is the bevacizumab related toxicities, and when we talk about hemorrhage, it's certainly more of a concern than with the IO combinations for obvious reasons. But if we talk about the two IO combinations, don't forget Stride again is just one dose of tremelimumab, whilst EP-Nivo you are going 4 times. You can see that with the 4 times of EP-Nivo, while you had such impressive overall survival and duration of responses, you do also have to deal with higher grade 3-4 immune-related adverse events of 28%. And about 13% of patients in the EP-Nivo arm discontinued due to toxicities, and up to 30% required steroids for immune-related toxicities, which is not low. So this is a concern for many of us. 20% in Himalaya, which is also not that low, but it's it's one of the things that we have to deal with when we use with IOs. Apart from combination therapies, don't forget we have data in single agent IO in first-line setting. In the Himalaya, there was a secondary endpoint and an arm of just Durva alone, and that was compared to sorafenib, and it was powered to show non-inferiority, and Durva was shown to be not inferior to sorafenib in terms of OS. The Checkmate 459 did not reach its primary endpoint, though there was trend towards superiority of Nivo over sorafenib. But Rationale 301, which is a more recent study, also China NTPD1, showed that tislelizumab was superior to sorafenib. Whatever it is, if you talk about single agent OS, you're getting median OS of about 15 months and responses about 15% or so. Okay. Again, don't forget in the first line setting, there's still good old sorafenib and lenvatinib. And lenvatinib is actually a very effective drug with quite good responses. Okay. And if you look at I forgot to point out just now in the EP-Nivo Checkmate trial, you look at the lenvatinib, sorafenib arm, the TKI arm, low arm, the median OS is really very impressive. But that's probably because they went on to receive subsequent immune IO therapies and effective therapies. Okay. So how about second line and beyond? Really, apart from treatment after sorafenib, which in 2024, that seldom happens, there's really no randomized controlled data to tell us what's the optimal sequencing. Okay, so, but we have a lot of real world data. This is just one of the small studies that we did with our counterparts from Korea and Hong Kong. And we looked at all our post Atezo-Bev patients and then looked at whether they received lenvatinib, cabozantinib, or sorafenib. What we know is that after Atezo-Bev, about 70% of our patients in the real world move on to a TKI, and lenvatinib seems, at least in this retrospective study, to give us better progression-free survival of 6 months compared to 2.5 months with sorafenib. But there's no significant difference in the overall survival. But there is a prospective study, the Embrace 251. This study will look at patients who have failed Atezo-Bev in the first line setting, and then they'll be randomized to receive either Atezo plus lenvatinib or sorafenib. So the question of whether or not continuing the Atezo will make a difference, and this will be compared to the other arm, which is just lenvatinib or sorafenib. which will be a physician's choice. Okay. This study is recruiting and we'll have to wait for more data. But now that Stride Himalaya is an option, then how about if patients fail Tremi and Durva, what is the optimal sequencing after that? Or if Ipi-Nivo become approved eventually, then what do we give after that? What's the optimal sequence? I don't think we have the answers yet. Just to mention, because we're supposed to talk about IOs, that we do have data in the second line setting, but all this is after sorafenib, whether it's Ipi-Nivo from the Checkmate 040 study or Pembro in the keynote studies. There's data from all these trials, and the activity across the board is about the same as in the monotherapy in the first line setting. Okay. So obviously the question of continuing IO beyond progression needs to be answered at some point. So this is a recent presentation and that looked at patients treated with atezo-bev, about 571 patients, and to study why patients die after atezo-bev and whether or not it was mainly just progression. But they found that in this study by Dr. Seltzer, that it was hepatic decompensation in patients that had patients the worst prognosis following atezo-bev. And this was more common in patients with baseline LB score of more than 1 and patients with non-viral etiology, which could it be that these non-viral HCCs, we always see in the big trials, there's this discussion that they don't respond so well, do not benefit so well from IO combinations. Is it because they just is not so much that it doesn't work in them, but they are dying because of hepatic decompensation? Don't know. Okay. But this study showed that antiviral treatment may protect from decompensation, and really just telling us that the non-viral etiologies have a poor prognosis. Which leads me to patients with poor liver function, Child-Pugh B 7 to 8. Okay, I'll stop at 8. Okay, I think beyond that, it's a little bit iffy. We do have sorafenib from the Gideon study long time ago, the phase 4 study that looked at patients who received sorafenib, and we know that they do worse if you're Child-Pugh C compared to B compared to A. But in the B setting, sorafenib can still be given for a significant period of time. You can see here in the chart. Okay. But prospective data, we do have from Checkmate 040, which I was involved in the Child-Pugh B patients. We showed that in this cohort of patients, Nivo could be safely given, though they did do worse than the Child-Pugh A cohorts. There was no difference in terms of adverse events. Okay, and these results have been similar results have been shown in many meta-analyses and other studies as well. How about with combination therapy in the Child-Pugh B7 setting? In the post-hoc analysis of Himalaya, patients who were treated with durvalumab compared to sorafenib, if they had a LB score of 2 or 3, did better than if they received sorafenib. And there were similar safety profiles in both the LB grade 1 and grade 2 groups, grade 2, 3 groups. Okay, and with this combination of Stride, there was liver function. I don't have the slides, another chart. Was stable over time, so you didn't see that deterioration in the function that you can see sometimes with the TKIs in particular, and even with atezo-bev. How about atezo-bev in the Charles B setting, their real-world series, and this is just one of them. And they just showed that, again, Bs don't do as well, but in terms of adverse events, very comparable. So there are many factors for us to consider when we are deciding first or second line therapy in advanced HCC, and we don't have a clear answer for some of this at the moment, but certainly we have to factor in patient factors. Is patient suitable for IO? Is a transplanted patient, had a kidney transplant before, liver transplant before? uncontrolled or serious autoimmune disease. Whether or not we need a high response rates, we might be wanting to use something with a higher ORR, especially if there's tumor burden that is high or more aggressive disease. And of course, you have to consider, among other things, reimbursements and cost of drugs and what is approved in your individual countries. Yeah. So I just touched a little bit about ICI use with liver transplanted patients. There is some case series data out there, and this was one of the reviews looking at pre-transplant immune checkpoint inhibitor use and post-transplant outcomes in HCC patients. Because now we are getting such good responses. Some patients still amenable to a liver transplant after IO use, or should we still, these patients, let's say the tumor is amenable to a transplant, not for the fact that they have ICI. I think this is being investigated in some studies, but I think the sweet spot so far, based on the data, is at least 90 days after the last dose of immunotherapy before performing any liver transplant. And with each 10-year increase in the patient's age and 1 week increase in ICI washout, this was associated with reduced chance of allograft rejection. However, I think in our daily practice, I don't know about you guys, but we are still very careful. Liver transplant is a very precious organ. It's very hard to get that transplanted liver, and to have and you don't have, like in renal transplant, where your transplant fails, you can still do dialysis. So we would be very desperate if we use IO in liver transplanted patients. So this is just one of the studies looking at that. So I'll just share a case study of a patient who, 75-year-old retired businessman. So he had stroke at least 3 times in life, and the last stroke was in 2017. And he's essentially has left-sided weakness, is chair-bound, and on Plavix. He also has diabetes, hypertension, high cholesterol, and is a Hep B carrier on tenofovir. So he went for a routine checkup and was found to have abnormal mass. And eventually was diagnosed with a 8.6 centimeter by 8 centimeter segment 6 lesion. This was confirmed on MRI, arterial enhancing, centered in the right liver lobe, as shown in that. This is a PET image. And also had another smaller lesion in the left lobe, and also IVC tumor thrombus. Okay, the AFP was 53,927, but his liver function was good, Charles-Pugh A5. So what did we do? So we gave him the strike regimen. Why? I was thinking this is a guy.
Dr. Su, can I request you just wind up? We are actually running out of bit time. We need to finish.
This is the
other
last
cases.
2 slides.
Yeah. Thank you.
So this is just a guy that we gave strike because of his history of stroke. I wouldn't give Bev to this gentleman. And you can see the amazing response. July 2023 in the scans here, and then the tumors have responded. And we've offered him surgery, but he's saying he had a lung met that disappeared as well, one solitary lung met. And we thought, look, we can go for surgery now, but then he's scared of surgery, and then the option is, should we even bother surgery, or is he almost in CR, and we could just keep going without any surgery, and the AFP continues to drop. It's still a discussion ongoing. So this is showing you this again. I think this issue of tumor stage migration, I think my point is that patients in advanced stages of HCC, we shouldn't just write them off. We are seeing fantastic responses, and we are going to switch patients from systemic therapy to local therapy, and we can even render them cured. So this is what we call treatment stage migration. Okay. So in conclusion, immune checkpoint inhibitors are really now part of treatment in HCC, not just in advanced setting, but in advanced intermediate setting, and has transformed survival outcomes making incurable HCCs now potentially curable. But we still don't have clear biomarkers to determine what's the best treatment option to date. And we really need to manage toxicities, which I have no time to talk about, but the treatment of HCC continues to evolve. Thank you.
Thank you, Dr. Pin. That was a fantastic lecture. I'm sorry I had to just stop you in the end because we are
No
running a bit
problem.
out of time. But a
Yeah.
great lecture and again a great learning. So the whole purpose of today's meeting has been to emphasize the role of multidisciplinary tumor board in managing HCC. And again, the cases that we have selected today are going to be including both early stage, intermediate stage, and advanced stage. The idea being that we are going to be seeing a lot of cases which are involving the use of immunotherapy beyond the traditional ways we have been using it. So without ado, I'll just call upon the first team. The first team is from Ahmedabad and Dr. Viraj will be leading that. So over to you, Dr. Viraj.
Thank you, Dr. Vamshi. So without wasting time, let me call my team. We'll be discussing the first case, which will be on early HCC. And our team includes 5 doctors, including me. I'm the medical oncologist. Dr. Hirak Vyas, if you could come to the podium. He's a radiation oncologist specializing in SBRT for liver, actually. Then we have Dr. Rosil Gandhi. He's an IR specialist. We have Dr. Patik Parikh. He's a hepatologist. And we have Dr. Hitesh Chawda. He's a liver transplant surgeon. So the format of this discussion for the next 20 minutes would be Dr. Hirak Vyas will be presenting a case for about 3 to 4 minutes. We will have an internal discussion among us 5 for about 10 to 12 minutes. And then we'll invite other 5 centers to open with the questions and give their comments. How would they do the same case differently, or would they concur with the management? So Dr. Hirak, let's start with your presentation.
Good evening, everyone. I'm Dr. Hirak Vyas. I'm a radiation oncologist at Shalby, Ahmedabad. Great to be part of this great academic feast. Without much ado, I'll start my presentation. We are talking about a 63-year-old male who presented with a history of loss of appetite and heaviness in abdomen for around 4 months duration, who was a chronic smoker for last 25 years and a performance status of 0 with a sonography report showing a small hypoechoic lesion measuring around 3 centimeter involving right lobe of liver, no free fluid in the abdominal cavity. Next slide. Patient had a triple phase CT abdomen pelvis, which showed on arterial phase a hypervascular mass lesion in the right lobe of liver, around 4 to 3 centimeters. Rapid washout on the venous phase, no portal vein thrombosis or no metastatic liver lesions. MRI also showed the similar findings. Patient underwent biopsy, USG guided biopsy from the lesion, which showed hepatocellular carcinoma differentiated, arginase positive lesion, child poke A, and Barcelona classification of A. So patient was planned for surgery, but could not obtain fitness due to cardiovascular disease and cirrhosis. So underwent transarterial chemoembolization in July of 2023, followed by 3 cycles of atezolizumab with bevacizumab till January 24. We repeated the interval CT scan around 10 months from the primary diagnosis, which showed a well-differentiated subcapsular lesion around 43 into 22 in the segment 6 of right lobe of liver. If you can appreciate, partly filled with hyperdense lipoidal particles, post-taste status, and mild peripheral capsular enhancement in the delayed phase. So patient was offered stereotactic body radiotherapy for the lesion. He received 48 grain 6 fractions and another 3 cycles of atezolizumab with bevacizumab till March 24. Patient recently had another follow-up CT scan which showed no active lesion on the CT. So we will continue with the discussion. I'll head to Dr. Viraj.
Thank you, Dr. Gita. You can join for the further discussion. So on this case, we are going to have Q&A with my panelists. And because this is the starting of the case, this is the first case, I would like to actually take more inputs on the basics of HCC, the etiology and screening. And to answer that question, I would invite Dr. Pratik Parikh to ask this question. Is there people who may with hepatitis B positive? What is, in your practice, you see the etiology currently building up to this community? Like, are you seeing more viral nowadays? Are you seeing more non-viral? Can you take that question?
Previously, I would say pre-COVID era and the post-COVID era. So pre-COVID era, we used to see many hepatitis B related accesses. Nowadays, post-COVID, I say that hepatitis B and steatotic liver disease related HCC is the.
Dr. Viraj, can I interrupt? I'm sorry, your voices are not very clear over there. I don't know about the other centers if they can hear you. How are the other centers? Can you guys hear Anant and all? You can hear. Okay, fine. Maybe it's then our fault. Okay, go ahead. Yeah, Gangaram also can't hear very well. So.
Hello.
Yeah.
Vamshi, can you hear us from Gangaram?
Yes, sir. We can hear you.
So I think we have a team here with the interventional radiologist and surgeon and gastro people, Dr. Ashish, Dr. Arun, and Dr. Shasta and Dr. Aditya. So we have a little a different point of view in terms of managing this particular patient.
Sir, I will get back to you, and each center I will ask again what they are going to do for each case. So first, let Ahmedabad finish it, and we'll have 5 to 10 minutes at the end to discuss all our opinions.
Undergoing, this major resection.
Yeah, go ahead, Dr. Viraj.
This patient had a solitary tumor 4 centimeter in the right part of the liver, although the vessel was slightly closed. Why do you think in this case the surgery was not considered, although they have said medically inoperable? But tell me more that in a solitary lesion with 4 centimeter, when would you not operate? Or would you think local regional therapy is equally effective when surgery is possible?
I mean, for this particular patient, as it was non-cirrhotic, and there was a single lesion of 4 centimeters, he is 65. I think surgery is one of the best options for this person. I would have accepted him. I don't know why why he was rejected. I mean, unless if there is any serious cardiac. Yeah, otherwise surgery would have been the best option.
So, Dr. Rosel, let me come to you. Would you agree that a local regional therapy, TACE or a TARE, can be a substitute for a BCG, non-therapy, where surgeon says I can operate this? Or would you still want to prefer surgery as a go-to in a 62-year-old male? I think if the fitness permits, surgery is the best. If the surgeon says no, or if the anesthetist says no, then in this type of cases, 4 centimeter, which are borderline, TACE plus ablation. If the tumor is near abutting the vein, then TACE plus microwave is the good option. And TARE, when would you do, sorry to interrupt you, when would you do only TACE, and when would you add a second local regional therapy, like you said, either RFA or microwave? So a 5 centimeter lesion, only TACE, but 4 centimeter lesion is a borderline. So we want to go as much curative as possible. Then TACE plus microwave is a better option. And 2 centimeter, only ablation. 3 centimeter, only ablation. Okay. So 4 is the borderline. 3 is ablation. 5 is TACE alone. 4 is dual. And also the paradigm, there's paradigm shift in the TARE. So what happens is we used to do palliative TARE when there's portal vein thrombosis. Now there is a thinking of curative TARE where radiation lobectomy is offered. So SIRT, when the surgery is not possible, inject the high dose of radiation in the lower artery, and ultimately there is atrophy of the tumor and that entire lobe. Dr. Chawla, let me come back to you. So in case if you were going to do the surgery, would you do the biopsy?
I mean, we missed out the slide for liver function testing out of it.
They're not.
If it is classical characteristic of HCC,
Yes.
I will not do biopsy. If there is atypical, I will do biopsy.
Considering radiologically classical,
Yes.
but here we normally in a hepatitis B.
I'll also do a PICA. Now we do it clinically. So PICA is done in all.
So in this case, it was not done.
Yeah.
So you would have added.
Yeah. So
Right.
if there is any doubt on, we do more MRI now than CT. So if there is any doubt on,
Just for the student, how much specificity would you add to that PIVCA? If PIVCA is elevated, do you have any other cause or it has to be elevated?
I don't think so. So if it is very high, then we do see now lot of PICA positivities.
Dr. Pratik, can you enlighten us?
For this patient, I think non-cirrhotic HCC, I would have biopsy. So my legs is applicable only for cirrhotic.
Correct.
So I would prefer to get a biopsy. So while before undergoing a TS, I would say an ablation with a biopsy, and then for a residual lesion, undertake a TS as a second CT rather than an oncology.
Excellent. So very important message to students. There was a question in the Dr. Choo's presentation, when would somebody do biopsy and when would somebody not? In a non-cirrhotic patient, Viraj does not apply, and hence this is a patient where one would want to do a biopsy. Now, let me come back to you again. When would you consider transplant in a patient who is not cirrhotic? Or it is not the option?
No, as far as possible, if it's a resectable tumor, it should be resected because it has a reasonable 5 years survival, survival. If it's a non-cirrhotic, then depend on the expertise of as far as resection would be a preferred option.
So when would you consider transplant?
Or more transplant operable, you downstage the transplant.
No, I mean,
It is not cirrhotic or cirrhotic.
not cirrhotic.
Transplant can be done as an upfront treatment. This way.
So that's what I'm asking. Resection versus transplant.
I would prefer resection first, prefer resection.
Okay, Dr. Kirat, if I can come to you, SBRT is, we are using it now regularly. It is also available in the government schemes. So if you have to choose between TACE and SBRT in a 4 centimeter right-sided tumor, how are you placed? What are your thoughts?
We have multiple impact calculations from entire world. Latest one from the clinical trial, which suggests that SBRT has a loco-regional better results as compared to TACE. If we do not go into the phase 3 of better results, it is comparable to TACE. That is the first thing that we have established over the years. So why not offer a non-invasive treatment first with an SBRT, where you can offer a curative treatment without even introducing anything in the patient, where you can get the similar results of what you are getting within a span of 2 weeks.
But you do agree that we don't have an RCT, right?
We don't have an RCT, we don't have a phase 3 data on it.
Although, so now many people are preferring SBRT also wherever it is available. So Dr. Vamshi, you can stop me when we have last 5 to 7 minutes, and I want to invite other centers as well. And until then, I can keep going on.
So Viraj, I think you have a couple of minutes more because it's almost 7:30. Because I think this case is actually going to ask a lot of questions. Like Dr. Shyam said, we are going to have questions on this case. I can just throw one to your team as well as to why transplant was never considered in this case. Is a 4 centimeter falling well within any criteria of any surgeon that I know of. Why not a transplant why it was not considered? Just financial issues or logistics or any other reason?
Yeah. So I would want my liver transplant surgeon to answer this, since he said if given an option, he would prefer resection and not transplant. So
Yeah, either of the two. Either of the two. It's a 4 centimeter lesion. You could resect or you could transplant.
But so correct. So that is the question. So in the case that we discussed, it's a borderline where anesthetic fitness was not there. So you could further argue that what part of anesthetic fitness was not there. He was child QA. But I would say even if there is a fit test, my question was resection versus transplant. I think so that has to be categorized very clearly. But I have one last question, and then we can invite other centers. So again to my IR colleagues, once you do TACE, would you recommend doing additional immunotherapy like this patient had? Or do you think additional immunotherapy was not warranted?
So in MRI after 4 to 6 weeks, if it doesn't show any residual tumor, then I don't think any additional treatment is needed. In a smaller lesion.
Yeah,
If the lesion is 5-6 centimeters, then there's always some residual lesion there. Then immunotherapy, adding an immunotherapy is better.
Right.
But if there is no lesion on MRI, if the CT showed nothing, no arterial enhancement, but with lipid, there is always some artifact. But an MR would be better. And if it doesn't show any enhancement, then the lesion is already necrosed.
So last month we had discussion on Emerald-1 study, which has adjuvant durvalumab plus bevacizumab after TACE improves progression-free survival. Are you sold on that, or you want to still say there is no OS, so I'm not going to do it?
But no residual lesion, and then why?
Okay.
It's unsuitable and it's a case suitable lesion less than 6 centimeter, a single lesion. It was a classic. You have decided to go with TACE as a first line therapy, and then it falls into a TACE suitable lesion. And adjuvant as of now is not an official recommended treatment. So, and that going for a immunotherapy in this patient without.
No, I'm saying adjuvant after TACE. So, by the way, durvalumab has already filed for approval. With durvalumab plus bevacizumab is adjuvant. Any other centers have any questions?
Yeah. So we will start with Gangaram because they are the experts for this panel. So Dr. Shyam sir, your thoughts on this? And I think one thing which Viraj has clarified is that there's a surgical issue. That is why they could not do a resection. So let's stick with that. Anything beyond that? Because I know you would again ask why not surgery, and you said you disagree with the line of management. So please, Dr. Shyam.
Difference of opinion, as I said. So I think we have Chief of Liver Transplant and Chief of Interventional Radiology. So I'll invite Oshas Dheer to give his comments on, because I think there were questions pertaining to surgery versus transplant. Let's keep aside the issue of the patient not able to undergo surgery, but let's have Oshas Dheer's opinion.
I can say that we would, if this is a child A cirrhotic, we would have tried to make him fit for surgery, and I'm sure our cardiologist would have made him fit for surgery. That's one comment. My anesthesiologist would have made him fit for surgery. I'm very sure about it. And if it's a child A, yes, we still can consider resection depending on how good is liver function, one, and second, whether I am supposed to do a parenchyma sparing surgery or whether the patient needs a major hepatectomy. If it's a small resection, then okay. If it's a major hepatectomy in a cirrhotic, yes, risk of decompensation is there. I would rather consider a liver transplant in this patient upfront, definitely. Second, if surgery is totally out, even our cardiologists were not able to make him fit, then I think I would have involved Shyam sir and referred him to him.
I think the case, Dr. Ashish is also here. Yeah. So any comments on the liver status?
So first thing, one of my comment is why was tumor biopsy was done, and if tumor biopsy is being done for some reason, then the biopsy from the normal part of the liver should also have been done to categorically rule out or rule in cirrhosis, because the management changes definitely. So if the patient is of cirrhotic patient with a tumor, then liver transplantation would be the first option if obviously medically he is fit for that. And if it is definitely non-cirrhotic, then also surgery comes first. Okay, resection is the first line treatment option for this kind of treatment, tumor which is small in size, 4 centimeter. And if surgery is not being done, then obviously intervention radiology, TACE is the treatment of choice, and we need not follow it with the immunotherapy which was done.
We'll come to Ashish. So I think, what about microwave ablation, Dr. Arun?
So before going on that, I would like to comment all of my 3 colleagues, the surgeons, the astrologers, everyone would have referred this case to me. After that, how would I have looked this patient? I would have looked that it is a curative patient. I would have not given the TACE option, isolated TACE option to this patient. I would consider him for potentially looking at potential cure of the patient. So if we see our Asian guidelines, TACE plus ablation should have been given to this patient, or if you are not sticking to guidelines going haywire, I would still given an option of TARE with radiation segmectomy. This is a beautiful candidate for radiation segmectomy, and this would have given a potential cure, one-stop treatment. Regarding again, just to what Rosal has said about the imaging, see, we are not sure that there was enhancement. MRI should have been done. It will be perfusion defects because of the TACE has blocked some of the arteries. So these are comments from my side. So we'll look at the patient that this is definitely a potentially curable candidate. Lingering his disease for long should not have been given.
Excellent. So I think I'll just make a blanket statement across the table. All decisions should be done in an MDT, and imaging is not just one imaging. I think this is something which I have learned over the last 2-3 years. If anyone says do one imaging, it's not like that. You may need to do multiple imagings. MRI gives you some different information. A CT gives you a different information. So we should not just stick to one imaging. Like Doctor just now said, if you have to do an MRI, you should do an MRI to clarify your anatomy more. And I think that's going to be a standard for all cases to go from here. So I'll just quickly go to Dr. Pin today. Your comments on this case. And again, I would like you to just focus on the second part, post-TACE.
Yeah,
the guidelines
I know,
are very
because
clear.
I'm the oncologist, I'm not the surgeon.
Yeah.
I'm not here to tell you whether it can operate or not. But assuming this patient had TACE, is a nice lesion, it's 4 cm. I wouldn't have given the adjuvant atezo-bev because if you look at Emerald, if you want to extrapolate from Emerald and apply Emerald, those are lesions that were more advanced in disease, 5 cm and beyond. And I would be concerned about toxicities. And then atezo-bev, you want to follow Emerald, then it's until progression. Not then when you stop the treatment is I can't remember, 3 or 4 cycles. Is that enough? I'm not sure what the answer is. Yeah.
Okay, thanks. I think I was looking for it because the guidelines the trials have used a more high risk patient. Actually, it's more than 5 centimeter or 6 centimeter. Yes,
and,
so 4
centimeter. Someone mentioned there's no OS, it's just PFS benefit.
Yes.
But I think PFS is meaningful in the advanced setting because, yeah.
Perfect. So we'll go to Max Delhi. Any comments from Max? Beyond what we have discussed. Anything else? Okay. Okay, fine. I think there's a huddle going on, and final conclusion is they don't want to add anything more. All right, TMH Mumbai, Anant and your team, anything you want to add in terms of the adjuvant? So let me broaden the question a little bit. Have you started doing adjuvant immuno, at least in the setting of the trial, the similar cases, a 7-8 centimeter TACE, stare done? Would you add immunotherapy? Have you started doing it?
Am I audible, Dr.
Yeah, we can hear you.
Yeah. So we have counseled a few high-risk patients as per the trial criteria, but I think only one of our patients has been started on that. And that's just our limited experience with it.
We have a couple of patients.
It's too early because the follow-up is only 17 months. I would want to wait a little more.
I think we have a couple of patients whom we started again in the same scenario with what you are saying. So over to you, Viraj. Any last comments from your side? Otherwise, we'll go to the case 2.
No, so let me ask my panelists. So they have heard the comments from other centers. Dr. Chawda wants to make a comment.
No, I just want an opinion. Suppose if you resect this patient and is not cirrhotic, what is the current status of starting adjuvant treatment?
So I think, Dr. Pin, I leave this to you. What is the current status as of? Dr. Pin, you are on mute.
Okay, sorry. Yeah, so I think it's still as per the Embrace study, the Pierce Child study. They have to be high risk. Otherwise, this guy doesn't fit the high risk criteria of you have to have microvascular invasion, 5 cm or more, and so on. Otherwise, and even then, I think in our practice, because of it's not I don't know about you guys, but in our practice, we have a discussion, but we don't give it across the board. It's it is still not something that we apply across the board in our practice because of cost, because of toxicities, because we haven't seen the ultimate survival benefit. Yeah.
Excellent. So I think that's a good first beginning. And again, I think all of the people are listening. I'm told that there are more than 100 individual logins who are listening in. So the message to you again, I think will be made through and through this entire discussion today. Have an MDT, sit across the table from each other and discuss. That is the best way to get the right treatment choice for the patient. So thank you, Viraj and your team. Next will be the team from Max Delhi. So if you guys are ready, you can start your case discussion. Dr. Bhuvan, I can see you. Yes, Dr. Bhuvan is there. Please go ahead.
Treatment without MDT. So this again is one of the cases which is an example of a good MDT, and how do we end up performing that? Obviously, the time will tell. But I think let's dig deep into it. With Dr. Shaleen being there, with me being there, I think we're missing the intervention radiologist guy, because I think his inputs would also be needed, and I don't know if we have one on the panel here. I think let's move and then we can have a discussion about this case.
Good evening, everyone. Thank you, organizers, for the opportunity. Good evening, everyone. Thank you, organizers, for the opportunity. I'm Dr. Adra from Max Medical Oncology. Next slide.
Next slide.
Next slide. So the cases of a 41-year-old gentleman educated with adequate caregiver support and is a graduate with no financial concerns and resident of Dehradun.
Next slide.
So in 2023, he presented with abdominal pain and he has HBV related CLD, and USG whole abdomen done in 13th June 2023 showed mild hepatomegaly with large liver SOL and splenomegaly. And his AFP was 12.12 nanogram per ml. So the CT scan, which was done in 14th of June 2023, showed an enlarged liver and marked hyperplasia of left lobe of liver. And there was a large hypervascular mass measuring 14 into 13 into 14 centimeter, occupying almost entire segment of segment 7 and segment 8 of the liver. There was no evidence of any tumor thrombosis. And these are the images with showing a 14 centimeter large mass with the central necrosis. And he was diagnosed as HCC BCLC class A because of single liver lesion, and which was initial stage, and PS performance score was 0 and child book A6, the etiology being HPV related CLD. So in June 2023, he underwent a DSA with transarterial arterial chemoembolization, and he presented to Max Healthcare. So upper GI endoscopy done was showed a grade 1 to 2 esophageal varices, and we got a whole body PET CT scan done, which showed the same findings, like 15 into 14 centimeter mass involving the segments 7, 8, and 4, and moderate enlargement of the right lobe of the liver with atrophy of the left lobe of liver, and it had post chemoembolization changes also. So, and a triple phase MRI was also done. It showed the same findings of an enlarged liver, large mass of 17 into 14 centimeter, occupying almost entire segment 7 and 8 of right lobe of liver. And so these are the imaging findings of the MRI. And at this point, his PIVCA value was 6,187, and because of the large lesion size, he was planned for 3 cycles of atezolizumab with bevacizumab therapy. And the first cycle was done on 25th of July, and he completed the third cycle on 7th September 2023. And his PIVCA before the third cycle of targeted and atezolizumab showed 1059 was the value, and the PET-CT which was done post completion of 3 cycles of therapy showed an interval decrease in size and uptake and metabolic activity, and it was suggestive of partial response to therapy. So he also got a PET-CT done 2 to 3 months after the initial PET-CT, and it showed there was a large mass with central necrosis, but there was a response to the treatment. So further treatment and MDT discussion was done, and he was started on lenvatinib 8 mg from September 2023, and his PIVCA2 dropped down to 29.54 in January 2024. So he underwent living donor liver transplant LDLT on 9th of January 2024, and the intraop findings showed a large steatotic liver, and gallbladder was non-distended. There was no ascites or no PVT, no peritoneal pelvic metastasis, and SOL was noted in the segment 7 to 8, which was 15 into 15 centimeter. So this is the post-op histopathology. It showed that the tumor size was around 15 into 11 into 8 centimeter, and there was a capsular breach. So it was hepatocellular carcinoma with 80% necrosis grade 1, PT3 due to the size. So follow-up, he was on lenvatinib 8 mg orally, and he was tolerating well. And the MRI showed post-liver transplant recipient status, which the transplant liver appears normal, no focal lesions or no other enhancing lesions with a mild splenomegaly. Thank you.
So I think let's have the cameras. Yeah. So we basically, I think the case given to us was a 10 to 12 centimeter BCLC-B. Now, as per the BCLC 2022 update, any single lesion in the liver, whatever size may it be, will be BCLC-A and not B. So this gentleman had a 15 centimeter mass, which for which he underwent a TACE, and then he had underwent, because of the large mass, we wanted to check the biology. We took him for the systemic therapy. Then the concerns came that can you do a transplant or not? And plus, having given BEV, we gave him 3 months of lenvatinib because we were preparing our trial. LDLT, we had the MDT discussion. And from there, he has undergone a LDLT and is tolerated fairly well. So I think the questions can be many, but let's have a discussion with Dr. Shaleen also, who's the liver transplant surgeon, and let's understand the surgeon's point of view in terms of whenever you're dealing with a large mass, how do you approach that?
So this patient, actually, this is kind of I would say there's only one case report published in American Journal of Transplant from Bangalore, similar case.
Doctor, a little bit louder. We're not hearing you. Yeah.
Hello, am I audible now?
Yeah, better.
Hello.
I think there is an issue with the, otherwise his
yeah, I'm pretty loud in this.
Yeah, it's clear for us. It's the mic, not you. Yeah. Please go ahead. We can hear you now.
Okay. So these are kind of cases where you have very limited therapeutic options. You have a young patient who's fairly well preserved but has a cirrhotic liver, a large tumor. So he's already been tased outside, partial response, still continues to have high tumor markers suggestive of an aggressive tumor biology. So the therapeutic options in this case, which we thought best, was that atezo-bev has shown very good results, especially in a limited number of patients, not all patients. So we thought that he's already undergone TACE. So the next line of therapy could be, you could talk of SBRT, but we thought that immunotherapy would be a better option in this particular patient because the risk of decompensation was there. There was hardly any left lobe in this liver, and almost the entire right lobe was occupied by the tumor, though there was partial response to TACE.
but there was hardly the very little functional liver parenchyma, though he was child 2 status was varying between A to B. So we thought that would be a good option. And after 3 cycles, he showed response, but still we wanted to see the biology because transplant is a big decision for the family as well as the treating team. And then you always have a high recurrence rate, though it's in our view that it gives, and as per the literature also, it gives the best response amongst the all other therapies in similar in such kind of situations. So we waited another 3 months after the 3 cycles of atezobev, and fortunately for the patient and for us, the PIVCA values nearly normalized, and there was very good response on the final PET CT that we did. So we were confident enough, and then we prepared a donor, went ahead with transplant. He's 6 months down the line. Till date, there is no evidence of recurrence, but I would say it's early days. So this is a kind of approach which is not being practiced. It's being practiced now, but we don't have a lot of data on that. So I think we have to see the results.
Interesting.
This
So
particular
Bhuvan,
patient, sorry.
Yeah, please go ahead. Please go ahead.
So in this particular patient, because of the paucity of multiple options, this appeared to be the best and seems to have worked well.
Bhuvan, anything else from your side you want to add, or we'll go to the questions from the other panel?
I think the one thing which I would like to add is the further drop in PIVCA from 3rd cycle to the January shows that there is a continued response with immune therapy, which we all know happens.
You gave lenvatinib.
Yeah, but then let's be fair. Let's call a fair opinion about it. Considering, and the second thing is obviously we are the second thing which comes out of is in a post-op therapy we are obviously doing a study for this, but in a patient like this, can you let them be without a systemic therapy post-transplant? That is one question which came out, and there has been studies by the Chinese studies in which they do post-transplant and post-resection. They continue on lenvatinib for a variable period of time. We have our own study going on in our center in which we take it from 6 months to a year. That's what we're doing for such patients. So these are the 2 unanswered questions as yet. But then let's open the floor and then we take the questions.
I want to make a point that he was on lenvatinib even before that. So we cannot attribute the response only to lenvatinib. That would be, I think, too far-fetched. But yes, there is no data or any RCT or very solid data support to support this approach. So I think in the absence of any relevant or very hard data, I think it's a fairly good approach, and he's still on lenvatinib. And as Dr. Bhuvan said, we are running a trial. So we are giving 6 months of lenvatinib to all such patients.
Perfect. So before I open to the Ahmedabad team, Dr. Pin, your comments. And again, after immuno, somehow I've seen a lot of surgeons, the old criteria that we were taught, the Milan, that this should be this size, this number. I mean, any BCLC-A which is responding seems to be going for a transplant. And I think that's not unique to India. That's pretty much in all the Asian countries that's happening.
Yeah.
Your thought on that?
Yeah, I agree. I mean, I think I applaud that this is a good outcome for the patient. Actually, I have more questions than, well, I have a question. I mean, my first question is, if he was responding so well at atezobev, could we have continued the atezobev, and did he have to undergo a transplant, and could he have avoided a transplant if he had continued response until he reaches complete response or near complete response? And if he had better response, would alternative local regional therapy be possible? Because now he's a transplant patient, and for the rest of his life he's immunosuppressed, right? Which it's a quality of life issue. I don't think we all have the answers. I just wondered what you thought.
I think there's no answer
I'm not
to
sure.
it.
Yeah.
Well, I'll interrupt there.
Yes,
Sorry.
sure.
So I think there is a very valid reason for doing a transplant. So you should not forget that he's a hepatitis B patient. So these patients, if you leave the need, first you don't have data that how many cycles of atezobev you have to give. And then it's not a drug without its own side effects. We have seen multiple patients worsening after atezobev. So you cannot have a patient, and then these patients tend to kind of run out of the immunotherapy and the tumor starts growing again. We have seen similar such cases also. Plus, in the presence of a hepatitis B with very little liver parenchyma, these patients surely tend to decompensate. And even if they don't decompensate, they develop new tumors in the diseased liver. So transplant is a very viable option, and you cannot just let these patients be indefinitely on immunotherapy. And as I said, immunotherapy not only has its side effects, but then you have to consider the logistics, the cost, and everything. So I think there's a lot of enthusiasm about immunotherapy, and there have been good results, but I think it's not an end in its end. So you have to consider multimodality.
I think this discussion of what is more cost effective, a transplant or immuno, will go on forever. I think let's not get into that. So Ahmedabad,
Not
over
only
to you
about
guys.
cost, it is the approach to the patient. Like you have to, in a hepatitis B patient, you cannot, cirrhotic patient, you cannot leave with that liver in the place.
Yeah, you're removing the
Yes,
underlying
correctly.
cause of the HCC. I understand that. Yeah, but I mean, I'm throwing it out for discussion. Yeah.
So let's have a
I think there's going to be no right answer to this. Bhuvan, you're saying.
So I was saying that, see, I don't know how your experience has been with Atezo-Bev, but Atezo-Bev has a problem that when you are in the mid of Atezo-Bev, and when the PIVCA is increasing first and then decreasing, you are never sure that you're getting the response or not. See, I hear you that 80% necrosis on an explant liver makes sense that it is responding. But when you're in the mid of giving Atezo-Bev, the response rate being 35% with a large 14-15 centimeter tumor, you're always on the edge. And when you're always on the edge, you may want to do a tear, which is one option there. TACE has already been tried. So if there is a surgical option, let's say this was a 7 centimeter tumor, we probably would not even think once about resecting it out. So what I'm saying is that it's easier said than done that leaving patient on Atezo-Bev, it becomes risky because you do not know when they will increase. You do not know whether the PIVCA will fall further or not. So I would like to ask you that once you're doing Atezo-Bev, how do you monitor such patient that they're responding or not? And what's been your approach?
So
I think,
Dr. Pin, please go ahead.
I mean, we don't use PIVCA in Singapore. We still AFP and imaging. Whether it is your triphasic CT scans, generally that's what we use for our HCC. I think it's the standard way of imaging. And I agree that not everybody has a Atezo-Bev response that is prolonged. There are some people who have very good responses, very deep responses, and then suddenly they just stop responding. But there are also some that just go on for a very long time. And I'm not saying this is wrong. I'm just throwing it out there that, our concept of sometimes we wonder, I've sent patients for surgery after very good response to immunotherapy. And I wonder whether I really needed to or not, especially when the tumor comes out and there's focus of HCC or hardly any HCC. But, we still want to go and operate on the patients. I think that's our standard of care still. And that hasn't changed. Yeah.
So I think, Bhuvan, again, to answer your question, we all don't rely on PIVCA at all. PIVCA as a reliance is not.
No, we don't have it. We don't use it.
We do on AFP and imaging. That is generally better.
The patient never secreted AFP.
Correct. So PIVCA as such is not a great marker. It goes up, down, and all over the place. As far as our experience, and that's what I think. So Ahmedabad, over to you. We have only 5 more minutes for this case because we do need to wrap up by 9:15. That's a cardinal rule of all discussions. We should not keep on going. So Dr. Viraj, from your side, any comments? And then I'll open the floor. I can see the Gangaram team wanting to talk, and TMH is very adequately fueled with food, so they'll have some questions, I'm sure.
Yes, so we have IR and transplant surgeon. They both have a comment each. Go ahead. With a 15 centimeter tumor, tear would be a better option rather than a TACE.
So this was in response to that, the TACE was done the patient came to us, he had already had the TACE. So we didn't think of going ahead for tear because of the costs involved. Yes, we are routinely doing tear for large tumors, and that point is well taken. That tear for large tumors, they're definitely better response. But since he had already had a TACE, and then we thought that, and since it costs around 15 lakhs rupees, so we thought that let's go on with the immunotherapy and wait and see. And that's how the response came.
Also to that point, somebody who has a 15 centimeter tumor and let's say has had you do a tear or a TACE, would you be inclined towards doing systemic therapy after that or not?
So Dr. Bhuvan, again, 15 centimeter fulfills the criteria. Dr. Pin was talking about the trials. All of those are included. This would be a high risk under any of those trials. Dr. Pin, am I correct?
Yeah. Definitely high risk.
This would be a high risk. So
Beyond
you
high
would
risk.
add immunotherapy in this case. Viraj, anything more?
From our transplant surgeon. So, Jordan, how long will you give lenvatinib post transplant? I mean, even if the follow-up is okay, will you still continue or will you stop?
Sorry, I didn't get
So
your.
they're asking about
I think he's asking about lenvatinib. Would you give lenvatinib even after even before or after the transplant? Is that what you're asking?
Yeah, so we are doing it as a pilot study, and we give all these patients are on lenvatinib for 6 months after resection or transplant.
So lenvatinib also is anti-VEGF. So, that is the reason I think the concern is for all of us, lenvatinib is also anti-VEGF. So, any wound healing issues, I think with lenvatinib also you might have.
We do it routinely as in our center. We are
Oh,
running
that's
this.
good. I'll wait for your results because this is very interesting because theoretically your lenvatinib has anti-VEGF action, same as BEV. So if you can give it there, you can give both. I think that's what I'm taking. So
We haven't
any
faced
questions
any
from
wound healing
Gangaram?
issues.
Gangaram has
Yeah,
raised his
yeah.
hand.
So
Can I ask Gangaram people to?
So I've got two comments. One, I would like to congratulate Dr. Shaleen for excellent. So you have actually demonstrated a downsizing of the tumor, downstaging, and then subsequently transplanting. So I have no, difference of opinion regarding the management, but I have difference of opinion about regarding the stage. Someone mentioned that would belong to BCLC-A. But in our latest INASL BSCLC staging, all patients who are beyond Milan criteria would go to BCLC-B, not BCLC-A. So this is for the students to remember. And regarding that,
I have a difference of opinion on that. So only a multinodular HCC goes to BCLC-B.
no, that was 2022 one.
He's talking about the INASL. It's a different classification, not the
So we have
BCLC that you are talking about.
reclassified, and now so all which are beyond Milan criteria go to BCLC-B, and then we do downstaging and then transplant and adding systemic. That is the course of management.
Okay. Dr. Ashish, you are absolutely right. This 22 modification certainly has put in BCLC a single tumor. They have not mentioned about size. Previously, it was a very strict like Milan 5 centimeter single or 3 nodules, none of them greater than 3 centimeters. So this dichotomy or this confusion is still persists. But I think what they have said, it's a single tumor, and I think size is not been included. And now INASL has kind of, I think, rightly modified that and put it into B. So
Yeah.
All right.
Size is important.
Yeah.
Okay. Comment from Dr. Vivek here from AIG. Dr. Vivek is our intervention radiologist.
If you have considered TAIR, similarly, TAIR will also include the FLR for the surgeon who wants the PVD. When we are looking at such a large lesion.
So Vamshi, we can't hear him much.
Hello?
Yeah, can you hear us?
We can hear you. You are always audible to us.
I'm always audible. Okay.
What we were telling is about if we can consider TAIR for such a large lesion. Hello? Am I audible now?
Yeah, I think.
Yeah, I think I've already answered that
Yes,
question.
sir. Yes, and not for this case, a similar size of the lesion.
I think if you're going for a transplant, it really doesn't matter. When you're transplanting, it doesn't matter for the FLR. You directly anyway remove the whole thing, right?
Yeah,
That's my logic. Okay.
There would be an option. You are right.
Okay, great.
Okay.
So can we have any comments from TMH on this, or we'll move on to the next case?
From Gangaram to Dr. Shaleen. Dr. Shaleen, is there a time frame that you would like to stop lenvatinib before you go in for LDLT? And what time after the transplant do you reinstate lenvatinib?
So we usually don't stop lenvatinib. It just continues, and when the patient gets admitted for transplant, just 2 days or 3 days prior to transplant, we'd stop the lenvatinib. And about restarting after transplant, so it is always started after discharge. That is usually 3 to 4 weeks, and that takes care of the wound healing and the other issues. But we haven't faced, as I said previously, any issues with wound healing, whether in the resected patients or the transplanted patients.
Okay, great. So
Shaleen, just a last question: that is there any data to support giving the lenvatinib post transplant in overall preventing the recurrence?
So I think they just answered that they're doing a clinical trial at a pilot study. So I think we have to wait for the results.
Yeah, and we're doing a pilot study, and the basis of the pilot study was the Chinese data in which they were treating the high risk patients for on lenvatinib adjuvant. So again, that's the reason we started this pilot study, because most of these patients, we felt that if we could kind of cover them from somewhere between 6 months to a year, I think that was the time when the recurrences probably were a problem for us.
Can I ask a question?
Yeah, Dr. Sumana from AIG wants to ask. She's a liver transplant surgeon. Loud, please. I think there's a
Hi, Dr. Shalin. Sumana here.
Yeah,
Oh, so
Dr. Shalin, can you hear? Yeah, please go ahead.
So I'm digressing a little bit here, though I'm going to ask the same thing now. So there was TACE done initially for this tumor, and there was 35% necrosis, if I'm right. Is it true?
80% in the final specimen.
Before the immunotherapy.
Yeah, prior to immunotherapy, there was a partial response. As you
Partial
rightly said about
response.
her.
So my question to you is, okay, now that it was a 14 centimeter and there was a partial response, why did you go for immunotherapy and not a retase to get it down little anyway, because you had already planned for a transplant? Because immunotherapy and transplant, obviously, till it is really needed, there are instances, case reports where there is, there are some people who are saying that there's a lot of rejections. Some people have noticed infections and all that. Why didn't we consider TACE?
So to answer that question, Dr. Sumna, since he was a non-secretor, so we went by the very high PIVKA values. So to us, it appeared that this is a very biologically aggressive tumor. He has already had a tear we thought of, but it was prohibitively expensive. So we thought that since it's a biologically aggressive tumor, let's go for systemic therapy. And the second reason for not going for other local regional therapy was because there was hardly any left lobe. The risk of decompensation was very high in this patient. How he survived the first TACE, because as you can see from the imaging, there is no left lobe and the right.
Yeah, I do see it. Yeah.
So these were the two reasons for going for systemic therapy in this particular patient.
So I have a follow-up.
Bhuvan, it's your case. Let's the others comment, because we are running out of time. We would let you comment on the others' cases. TMH, Anant, any comments?
Yeah. I'm very interested in this adjuvant lenvatinib concept because there is negative data with sorafenib. And so TKIs have not generally worked in the adjuvant setting. The second thing is, since the patient had a very good response post the atezo-bev, lenvatinib could have been avoided there as well and just allowed a washout for immuno before the transplant. So those two things were a little interesting to me, but hats off. That was a very aggressive, good approach for the patient, I think.
Okay, so Viraj, any final comment, or we'll move on to the next case?
We should move on to the next case.
Thank you. Okay, so the next case was supposed to be from AIG. We were actually going in sequential order for this, but I think Gangaram wants to finish the case earlier. So we will move on to Gangaram. Over to you, Dr. Shyam.
Yeah, so I think it's a simple case. We can have a discussion on the various options for a patient who has multiple, liver lesions. Can we have the slide? Yeah, so this is basically, we were told to showcase, I think it's a lady, 65 years. Yeah, next. Can we have the next slide? Next. Okay, so actually this is the first case in the sense that this, is a 68-year-old male with chronic hepatitis B with high alpha-fetoprotein and unresectable HCC. As you can see, multiple areas of disease in the right and also a few in the left. So the question is to Dr. Arun as to, would you be willing to take this patient up for some kind of intervention here?
So, I want to know the status of the portal vein.
Yeah, it's normal. Portal vein is known, there's no thrombus.
No thrombus. So, depending on the distribution of disease, this doesn't looks like a with curative intent, with palliative intent, I can offer tear. With we have to see the distribution on the left lobe, whether it is possible or not.
So,
can I interrupt, sir, for the interest of the audience? Like a tear would cover only the right lobe in this case, or you want to give some cover to the left lobe as well, or would that be a staged tear?
So it all depends on the distribution of the tumor in the left lobe. If I just look at these images, the two nodules, small nodules, it can be selectively tear if it has to go with a single therapy. It can be done. It is technically feasible.
Any limit to the number of lesions that you can have in opposite lobe? Because again, I'm a medical oncologist, my understanding is very limited. I thought that if you have multiple on both sides, tear becomes a contraindication. So I'm wrong in that.
So yes, you are wrong in that. It all depends on the distribution and how selective I can do the tear. It is not a lobar therapy. It is with advanced dosimetry. We have to treat it how we treat doing the selective TACE. Like if the tumor bulk is in the right lobe, we can do the right radiation lobectomy, and super selective tear is also possible. Covering only a segmental parts or subsegmental parts.
Okay, perfect. I think my intervention is nodding his head, so I'll go with this. Please, sir, Dr. Sham, please continue.
Right. So I think, I don't have to follow up on this patient, but then the point is that if this patient is not possible to, tear or TACE, Aditya, what do you think is going to be your treatment for this patient with a, child poo A situation?
So, any patient where we are not been able to, offer them tear or TACE and these kind of ablative therapies, I think the patient tantamounts to, systemic treatment. And once you have been, counseled the family, you are able to start the systemic treatment and see the biology of the disease. If you have been able to downsize the tumor and then again maybe do an MDT and ask Dr. Arun as well, will he like to intervene at that point of time? I think that becomes kind of a very selective approach, but yeah, in order to, do the justice to the case, I think better to start with the systemic treatment, if not possible. So I think if the patient obviously having no financial toxicity will be going with the immuno and the BEV combination, I think that's the way to go, but I think the lenvatinib is also a good option in this particular scenario because both have definitely shown a good amount of response rates in the multicentric bilobar kind of an HCC.
So Dr. Ashish, your thoughts on, NASH versus hepatitis B related HCC, do you think any difference in the outcomes?
So in this patient, he's a male patient with chronic hepatitis B. So, and we must not forget antiviral therapy in these patients. And also one thing which we need to emphasize is that we have to prevent decompensation as we progress down the line with systemic therapy as well as intervention radiology, tear and all that. There's a high risk of decompensation. So that needs to be adequately assessed, and upper GI endoscopy and all that has to be done. And as far as NASH versus viral hepatitis, there's been some data to suggest that immunotherapy works better with the viral etiology as compared to the non-viral etiology, but later studies have suggested both have equal response. So for this patient, I would agree with Dr. Aditya Sarin that possibly if the patient can afford, then immunotherapy, otherwise lenvatinib would be a good option.
So my final comment would be that from Dr. Arun, if you do tear or you do, systemic therapy and there is a significant downstaging, so should this patient, because there's no portal vein thrombus, so should this patient also be considered for liver transplant?
So the AFP is 10,000, which is clear cut out of the criteria for the transplant. And if we see the overall biological behavior by the treatment duration response and how the AFP comes down below 1,000, then we might consider at time looking the durability of the response.
Right. So I think, Vamshi, the other thing, of course, is the other thought of, after tear in such a patient, should we be adding atezobev or durvalumab as per the MRL trial? So that remains an option. But I think these are the issues we thought we can deliberate on in this case.
Thank you, sir. I think you have finished well on time, so we have enough time now for discussion. And a few things to really note regarding the role of LDT for the bilobar disease and the other issues. So can I ask TMH Anand to start, because you guys are the
Yeah.
experts for this.
So,
Any comments and questions and so on?
Yeah. Couple of things. So we have a team of 5 here. We have Dr. Alicia, who's a gastroenterologist, Dr. Tanya, who's our IR, and Dr. Rishabh again, who's IR, and Prabhat here, who's a medonc. So first, maybe we'll just talk a little about the Hep B thing. I think, I'll ask Dr. Alicia, and my question to her would be, how long should we give antiviral therapy before starting on TKIs or immuno?
We at least give it for 2 weeks before starting. So the viral load need not be negative, but the patient should be adequately covered with antiviral for at least 2 weeks before starting immunotherapy. Yeah.
So Anand, I'm from Ahmedabad. So in our practice, we typically start together with antiviral and immunotherapy. So can anybody elaborate that somebody should not do that?
So, Viraj, prior to the onset of immuno, most guidelines used to say 6 to 8 weeks of antivirals before doing anything. But I think most of us would be comfortable with around 2 weeks. I am not sure if you would want to start immuno and antivirals together. Probably TKIs and antivirals is maybe okay, but immuno, I would not be comfortable. I'm open to, what others have to say.
I think we'll be uncomfortable if it's a freshly diagnosed case.
Yeah.
You bring down for some time. 2 weeks, see, honestly, immuno is good drugs. They are not miracles that if you don't start it for 2 weeks, the patient is going to not get well. There's no harm in not giving a immuno for a couple of weeks before you start I think that's how I look at it. Bhuvan, any comment from your end?
Anyone else with, how long do they wait? Because I don't think this is part of many guidelines. Everyone says 6 weeks, 6 weeks.
Ashish?
Yeah.
Ashish, any issue on the viral load?
I would start both together, because there's no reason. See, the immuno will actually boost the immune response.
Not really. The immune system works in a different way. Basically, the immune system is suppressing your T cells. And in fact, the T regs and others T cells are being suppressed.
Yeah.
So, your activating T cells may actually increase. And that's why we see a flare phenomenon.
Yeah, the Hep C especially.
We would be a little cautious about that.
I'm not aware
So,
of
even the trials where atezolizumab combination have been tried, Dr. Aditya here. So, I think the trials have categorically mentioned that you need to treat the viral load first and then initiate any kind of systemic therapy, whether it is TKI or whether it is IO with a BEV combination. I think we should respect the trials, because we don't want to face any untoward circumstances later on in the treatment line. You can definitely end up, flaring the disease. You don't know how that patient is going to, behave in the next few months. So why to take that unnecessary risk and start with the antiviral therapy first?
No, but the 2 weeks of antiviral would not significantly reduce the viral load. So
Dr. Anisha,
one log reduction, not more than that. So
Dr. Alicia would just make a point here. 1 minute.
We don't have direct evidence from cancer trials, but the AJA guidelines for Hep B reactivation suggest that we should start it 2 weeks before starting drugs which might flare Hep B. So I think going by that, 2 weeks seems to be a reasonable ask.
I think 2 weeks is a reasonable ask, and it's not that if you don't give any therapy for HC for a HCC, 2 weeks nothing is going to happen.
Vamshi, maybe this is a debatable point.
Sure. Anand, go on. Next comment.
Strong yeses and no's
no
there.
Comment. No,
it's just a point that I think we should look into it. Let's put it at that. I'll just hand over to the IR people, and my question to them is that I actually thought if we had more images, and there's definitely no PVT, and I understand that they had said there was no PVT, why not TACE, and then you have data from Launch where lenvatinib and TACE was combined. You have data from Emerald where Durva, but why not TACE? That would be my question. Any of you?
Good evening, everyone. This is Dr. Rishabh. So, yes, I definitely second, sir, that firstly, we don't have the total information about the images as well. And looking at the two images which we have, multifocal HCC, yes, definitely we can offer TACE, super selective TACE. If we do, then we can get a good control of the disease as well. And later on, we can, as Sir said, then we can start on combination therapy, looking at the status of the patient, CTP score, and yes, we can definitely go.
So, in your opinion, where would you definitely say that, I just definitely want to do tear in a patient who doesn't have portal vein thrombosis? Where would you put your foot down and say, no, I am not going to do TACE? I mean, just for everyone
for
else.
TARE, I would say that there was a legacy trial which was done a couple of years back. So it had a very convincing data that lesions up to 8 centimeters, you can definitely go and target those lesions via TARE, and it had a very good response. And overall, like post TARE also, that trial showed a lot of patients undergoing resection, which revealed that a lot of area was necrosed post TARE. So single solitary lesions up till 8 centimeters that can be targeted according to the legacy trial as per.
Yeah.
So that has been included in the BCLC classification as well. Yes.
Okay, fair enough.
Was a PET scan done for staging the tumor?
No.
The AFP is so high, I would be really worried about extrahepatic disease in his case. Before deciding on local
Dr.
regional
Arun, you wanted to
immunotherapy, I
comment?
think that would be a major consideration.
Yeah. I think Arun wanted to comment from Gangaram.
So, regarding the role of PET CT, I would say that in very high AFP secretors, you can consider, but usually a chest CT is sufficient. You don't actually require a PET CT for that. If we go by guidelines and what is the practical system. If we just commenting on the about the difference between the TACE and TARE. So see,
So I think there's going to be never any answer to this PET CT versus not PET CT. So I think, again,
I think some centers are actually, instead of an FDG, they're concentrating on a FAPI PET. I think down south, there are more than a couple of centers who are encouraging it quite strongly, and there's some interesting upcoming data. But I agree with what Sir said. I think if you have a good CT thorax, I mean, a PET, can be avoided. I agree with that. Yeah.
So we are doing FAPI actually, and again, let's just say the results are not as conclusive as they seem to be. So it's again right now experimental. Sir, Dr. Gangaram is raised his hand. Sir.
So just want to complete my comment regarding the TACE versus the TARE. So the patients who are high risk for TACE, the TARE should be offered to the patients. Like the tumor burden is high, then possibly TARE is far better because of less toxicities and possibly some durable response. So my colleague was discussing about the legacy trial. So it was a single lesion. If we talk about even the multinodular tumor also, the dosimetry has so much of evolved that the TARE, we can treat these multiple nodules selectively with sparing the parenchyma with very less chances of decompensation. So those who are high risk are better candidates for TARE as compared to.
Yes, sir. Yes, sir.
I also think that the dosisphere study, I think, is the way to go. I mean, they gave, I think, 200 gray, close to that. And the results are quite spectacular, more than 200, right? So, yeah, that's it from our side, Vamshi. I hope we stick to time.
Yeah. I think it's been on time right now. Any comments from AIG? Any comments from any other center? Or I think this discussion of where TACE should not be done, where TACE should be done. So I think the other, if I can set the cat among the pigeons, is to ask the radiation guys that, okay, they'll do some TACE, you do the remaining SBRT. I think that combination is where it is coming in, or else you just do some TACE, continue your immuno, when it responds, give SBRT, or then give TARE. I think the whole crux of the matter is try to use as many therapies as you can to keep controlling and targeting as many lesions as possible. So thank you, Dr. Sham sir, from your side. So the next case will be presented at AIG. I will ask Dr. Anisha, who is doing her DNB residency from Indo-American Hospital at Hyderabad. She'll be presenting the case from our side.
Good evening, everyone. I hope you can listen to me.
I hope Dr. Anisha is audible. She's quite low.
Yes,
Good
sir. She
evening.
is audible, sir.
Yeah. So today's case is 38-year-old gentleman who presented with abdominal pain, and he's a known HBsAg positive patient. He was diagnosed with a liver lesion elsewhere, and he was evaluated for the same here. On evaluation, found to have chronic liver disease with raised AFP, and his Child-Pugh score was A6 and performance status 1, and there were no varices. And the PET-CT was done. It showed cirrhotic liver morphology with ill-defined infiltrative neoplastic disease process in the left lobe of the liver with contiguous portal vein thrombosis, LR5, and multiple nodular lesions in the right lobe of the liver, likely metastatic deposits, and mild splenomegaly. The final diagnosis was BCLC-C with portal vein tumor thrombus and no extrahepatic spread.
Sorry to interrupt you, but whosoever is handling the cursor, please go to the display setting on the top. Display setting on the top.
Display setting.
Display setting on the top.
Yeah, Viraj, what is the problem? I mean, you're not seeing it clearly, or there is a
Dual screen. So you need to change that setting from the display setting.
we have to share it. I mean, we are not understanding the problem. What is the problem?
So now we were seeing the dual screen, the first slide and the next slide.
Okay, you're seeing dual screen. You have to see only one screen. Please, we'll sort it out at this end. Yeah. Yeah, please go ahead.
He received SBRT to the portal vein tumor thrombus, followed by which he received immunotherapy around 4 cycles, post which we have done a PET again, and it shows interval significant reduction in the FDG avidity, size and enhancing component of the prior lesion, and entire left lobe appears to be shrunken with interval near complete resolution of the portal vein thrombus and no other lesions seen. So post which he underwent hepatectomy, living donor liver transplant was done, and the histopath showed multifocal lesion with tumor necrosis of 5%, and it was a moderately differentiated tumor with tumor confined to the liver and LVI PNI being positive and margins being free, and the lymph nodes were negative.
Thank you, Dr. Anisha. Thank you, Dr. Anisha. So, interesting case again from our side, which was including a transplant as well. Right. So this was a case, and I will ask Dr. Sujana, who is a radiation oncologist. We'll have again a lot of things to discuss one by one. First things, of course, is the role of the SBRT. Now, in this patient, we gave SBRT to the PVTT, so I'll let Dr. Sujana discuss the radiation part of it.
Yeah, so this patient is quite young. Even though the disease, the tumor burden is high, we thought we'll treat a bit aggressively from our end. So only the portal vein tumor thrombus was targeted, and rest of it we thought, the systemic treatment, and probably we thought we'll push the patient for transplant in view of his young age and good performance status. So we have targeted the entire tumor thrombus and gave a very good ablative dose of around 50 grain 5 fractions. So yeah, and after that, I think the patient went for.
So I think I'll ask the question here, which a lot of people ask, that the RTOG study showed that if you only, you should radiate both, then the benefit is more rather than radiating PVTT. So that's a question which people would ask you.
Yes, but the problem here would be the volume of the disease, what we'd be treating in the parenchyma. So the left lobe is kind of, if you have seen the images, it's a bit of an infiltrative tumor and it's not very clearly defined, and there are few metastatic deposits on the right side. So the volume would definitely go up. So that's the reason, after a detailed discussion in the MDT, we thought we'll only treat the portal vein tumor thrombus.
So Dr. Vivek, you were also part of the discussion that time. So the IR team, again, tear can be done as well to the portal vein. But would that, such a large lesion, infiltrative lesion, plus lesions on the other row, would that be a contraindication here?
That was the reason to not do the tear for this, because of the multiple lesions on the right lobe, and the tumor thrombus extending up to the main portal vein, and in the VP4 tumor thrombosis. So we thought in the VP4, the tear, the prognosis won't be that great with the VP4 tumor thrombus.
Okay. So again, the discussion when it comes to VP4, it's very interesting. VP4 is actually even not included in a lot of the immuno trials. The Atezobev trial has included it, which is why we gave it, but the VP4 is not even included in all the immuno trials. So, that's an interesting point. So in this patient, the patient was lucky enough to have a good response, 3 cycles. We actually stopped the bevacizumab for around 6 to 8 weeks and did not use lenvatinib. And then we went for the transplant. So Dr. Sumna, how common, see this image on day 1 with the PVTT, a transplant is something would be the last thing in our mind, but should we start considering these cases? Again, this is beyond all criteria. This is just evolving data. What do you think of this?
I agree with you, and we have presented our data also. We had 6 cases like this, and looking at the whole overall thing he's actually police. He works as a sub inspector, I guess. So with when we see these young patients coming up with tumor thrombosis like this with extensive disease, we always think of giving them a new adjuvant, or you downstage the disease and then take him up for transplant, which the ultimate transplant benefit is always considered in these kind of patients. So we always like we discuss this in MDT meetings, and our end point would be to actually transplant them.
Excellent. So I will kind of poke a stick into this. And the case which which Max Hospital presented, there was 80% necrosis. Here there was only 5% necrosis. That kind of is not a very nice thing, though the PET again showed an excellent response. So this is again to highlight to all the listeners. PET can show good response, but it is not always translating in the pathology, because here we had only 5% response. And in the case which Max presented, they had a good PIVCA fall and 80 to 90% necrosis. So, I think we are still learning what is the right thing to do here.
But you also should see that we have not treated the parenchyma here. In the case where Max presented, they have treated the parenchyma lesion.
Correct. So essentially what you're saying is the care and the other things did the job and not the immunotherapy did the job. So great. Thanks for the confidence in the immunotherapy. All right, sir, I can see the Max Hospital raising a hand. I will leave it to the Gangaram first to comment, since they are the experts, and then we'll take questions from each center.
So regarding the comment on this, I would definitely not use tear in this patient. This patient possibly must have not standard, and yes, the SBRT for PBT, so everything was done correctly in this case. So nothing to add on from my side.
Okay, so can I ask if there's any other radiation oncologist anywhere else who could focus on it? Because again, SBRT is something we are doing often now. Any radiation oncologist at Max or in TMH? No one? Okay, so I think Zuzna, you have the floor, and whatever you say stands today. From Max Hospital, sir, you had a comment, sir?
Yeah, so I would like to counter this. I have a different opinion on this, and I think somebody raised that point that only 5% necrosis is mainly because the main parenchymal disease was not treated.
Correct.
So that is a major factor, and transplant in these cases should not be taken lightly. We have more than enough data of more than 50 cases. Although Medanta and there's some other centers from Korea, they have published good results, but you do have to pay a price of early recurrence, higher recurrence rates after transplant in these patients. And I would tend to disagree a bit that tear should not be done. I would have preferred tear because that takes care of, one, it will take care of both the PVTT as well as the main tumor, though PVTT, you can give additional SBRT later on. That we have been doing, that combining loco-regional SBRT and then considering immuno later on.
So maybe we could have done a tear prior to the transplant. That is an option which we did not really consider that.
That is
if you are planning transplant, and the most important, the tumor marker levels were not mentioned in this case.
So this was a non-secretor, and they were non-secretors from the beginning. So that's why we could not follow up with the tumor marker. But the PET we did, and the PET showed a great response. So we actually kind of trusted the PET more in this case. I think that's the thing. So Dr. Vivek, would you want to comment on the SBRT part?
On the tear part.
Tear part, sorry.
Sir, with the multiple lesions in the right lobe with the tumor thrombus extending up to the main portal vein, in such cases, we would like to give a trial of immunotherapy and then see the response. And then if there is any parenchymal disease left, then we would like to do the tear. I think rather than going for the upfront tear, we have done few cases where we have done the immunotherapy, tear, SBRT, and then shifted the patient for the transplant. That would be my.
Can I have the opinion from the IR people in TMH? I mean, would you agree that tear in a VP4 with other lobe you would not do? or would you first give the SBRT and then add? Because again, SBR radiation is strong in TMH, so you would have seen these post SBRT cases.
So the extent of the thrombus in this case was like VP4, like the main portal vein was also involved. So in our experience, like the patients we have taken up for tear, such patients, they don't make it till long. Like the disease burden is such that the outcomes are not that favorable. So yes, giving a trial of immunotherapy and then taking up patient for further modalities could be one option, sir.
Yeah.
Okay.
Dr.
Yes,
Vamshi,
Anand.
one of the things that whenever we've had experts from outside, you, I think, part of some of these meetings, the moment they say VP4, they don't think of a loco-regional therapy at all upfront. They kind of just go with systemic therapy and then think of loco-regional therapy. And the thing with main portal vein thrombosis, I mean, a lot of people are doing transplants. I would love to see the long-term outcomes. You know, this median survival till date, if you cross 1 year with main portal vein thrombosis, is an achievement. So I want to know what the long-term outcomes. I think we need to look at that before considering very intensive strategies like a transplant in these patients.
I agree with you completely. And I think we have our data, which was 6 patients, what Dr. Sumana was saying, 6 to 8 patients we have done immuno and then a transplant or a resection. Sir was saying they have done 50. So I think that's the data set we should be really focusing on.
But it's a combination of all VPs, like VP 2, 3, and 4.
Yes, sir.
So
I think that data will really tell us a lot.
Yeah, so I would totally agree that, as I said, you have to pay a higher price in terms of early recurrence and high recurrence rates. And I would, in our data till date, we have about 70% recurrence rates at 2 years in these patients.
70% recurrence at 2 years. Yeah.
Yeah, I think that data needs to come out, sir.
We have done very well. VP2s and 3s have done very well.
I think that's a very fair data point.
Yeah.
I mean, you can always counsel the patient, and nothing wrong in going for a treatment if there's a 30% cure at 2 rate, nothing wrong in that. But I think the patient should be aware of that before going. I think that's a fantastic
Even
data.
our data was also like it's not always for VP4. We've had VP2, VP2, and VP4. I think this is the first one with VP4.
First one with VP4, yeah. So I think the best is, again, like we end up all conferences saying, pool our data and publish it, then we'll know what's happening. So I don't think there are any other comments from our side or TMH, any other comments from your side or any other center wants to comment on this? Viraj.
We're good.
Viraj, you wanted to make a comment?
Yeah. This is for Sumna and Shalin. So this was VP4, right? So post radiation, it becomes technically very challenging to build the inflow at the time of transplant. So this patient had a cadaveric transplant or a live donor?
No, it was a live donor. The splenoportal confluence was intact. So from there, we took an extension and gave the inflow.
Yeah, so sometimes, I mean, I was just wondering, treating this patient having a long-term thrombosis, so you do a thrombectomy or you resect it at the...
No, we don't do a thrombectomy because we initially decide that we are going to take an extension graft from the splenoportal confluence and then do it.
So Dr. Sumana, can I ask you any difference what you have noted post SBRT or post TARE in terms of difficulty in operating in VP1, VP2, or it's the same to you? Because ultimately both are radiation. One is given externally, one is being given internally as a layman.
We have done, to be very frank, we have done cases mostly post SBRT and not too many tears. We don't see much difference, I would say, in terms of
Could I ask Dr. Shine from Max Hospital?
They have much more data.
Yeah. Should I ask the Max Hospital their data?
I think tear for a surgeon, tear is a much better option because you don't see tear. It's a very kind of innocuous for the surgeon. Don't see any changes in terms of increased adhesions, which is a major concern. And we have a combination of both thrombectomies as well as extension grafts. But the thing is, the point I want to make is that if you are planning transplant in these patients, be as aggressive as possible in terms of your preoperative downstaging therapies, because that has a bearing on the outcomes. And SBRT focused on the tumor as well as some other kind of loco-regional therapy plus minus immunotherapy for the main tumor. If the patient is in a child safe status, should be the approach, although we need much more data, much more trials to that. But we have seen that if you are aggressive, then you have better outcomes, though our experiences like would say 2-3 years for these VP4s. So we always keep a donor ready in these patients, a living donor ready, telling the patient, counsel the patient One, about the high recurrence rates, and two, that you may decompensate as a result of these therapies, and that ideal waiting period of 3 or 4 months may not be possible in many of these cases. So these are 2 points I wanted to make about aggressive therapy and keeping a donor ready.
Yeah, I totally agree with Shalini.
So again, I think the end point again for all the listeners is do not dismiss every case off upfront and say this will never go for a transplant, especially with the advent of immuno and multidisciplinary approaches. You can take some patients for transplant, but I think Anant made a very fair point that we need long-term data before advocating aggressive therapy for everybody. I think that's a very important point that Anant has made. So there's no other comment here. We will move on to the last case, which will be by TM. Yeah, anyone wanted to make a comment? Okay, last case from TMH. So
One last comment from Ahmedabad.
yeah. Please go ahead.
Sumna, will you treat this? I mean, what's the adjuvant treatment plan for this patient? Again, very similar.
So we are not giving any
We don't
adjuvant
give any
post
adjuvant
LDT.
post
We have not done that. I think Max has made us think maybe we will try to look at it and whether we should start doing it. We are not doing it at
Yeah,
present.
we don't.
We are not doing it.
Take on this with VP4 lesion, PVTT, post transplant.
Post transplant, actually, yes. I mean, the thought of giving, because I think they're doing a pilot study. Are we really? We don't know. Are we really completely justified doing it?
VP4.
So we don't know the answer. Basically, we don't know and we are not doing it. I'll put it that way. We know that there is a higher chance of relapse, but whether doing this would help extra, especially when you consider the immunosuppression and you consider other side effects, is it risky? We don't know. So we are not doing it. But again, we have heard from Max today. So I think a lot of us will be now thinking at least of doing it. Over to you. Okay.
Yeah, so we have a case who initially was liver limited disease, then developed lung mets. Now, the points to note is that the patient was started on treatment in 22. So there are a lot of questions that can be, asked on why certain things were done, and I'll leave that open for discussion. The case will be presented by our second year resident, Dr. Balish Shenoy.
Hi, everyone. I'll be presenting a case on non-viral hepatocellular carcinoma. Next slide.
Can we see the slides, please? We are not able to see the slides. If they can be shared.
Yeah, we are also
I think
not
we've
able to
started.
see
Yeah,
it.
just started. You can go ahead. We can see the slide.
We can't see the slide. So we're just waiting for that. Hang on.
Okay. This is not in your auditorium, right, Anand? I mean, just a digression while the thing works out.
No, it isn't. It was already booked. So, and it's not available beyond 7 or 8. So,
oh, okay. So this is a separate room, is it?
Yeah, it's a separate place.
Oh, nice.
Yeah, just once in a while we go out of the hospital as well.
It's out of TMH. That's why I could not recognize. I was wondering where in TMH is this. Okay. Have you sorted out your slide issue?
Yeah. Not yet. Okay, just a sec.
So in the meantime, Anand, can I ask you, for the benefit of all the people listening, where should we stand on the whole viral versus non-viral for immunotherapy? Because this is something which, time and again keeps coming up. So what's your comment on it, or what's your take on it?
Okay, so we are good to start. Do you want to take these questions at the end of it?
Yeah, sure. We'll finish the case and then take.
Yeah, go ahead, Balish.
Yeah, hi. So I'll be presenting a case on non-viral hepatocellular carcinoma. So coming to resident of Mumbai, who is a PSU bank manager with habits of 360 ml whiskey per day for last 30 years alcohol consumption and 10 cigarettes per day since last 20 years cigarette smoking, with comorbidity of cirrhotic liver disease for the past 6 years and left leg varicose insufficiency since past 15 years, with no family history of cirrhosis or malignancy. At presentation, he had symptoms of abdominal pain since 1 month and early satiety since 15 days, with no weight loss bleeding, jaundice, cough, breathlessness, or abdominal distension. His performance status PS was 0, and there were no signs. So baseline laboratory values were hemoglobin was 12.6, platelets 239,000, creatinine 0.7, albumin 3.69, total bilirubin 1.5, AST ALT 6753, ALP 104, INR 1.12, viral markers non-reactive, and upper GI endoscopy only showed early esophageal varices with no PHG. Coming to baseline tumor markers, only serum AFP was done, which was 30,337. And the biopsy showed hepatocellular carcinoma grade 1 well differentiated. So the diagnosis was hepatocellular carcinoma, Barcelona stage B, ECOG PS0, child to Kortberg A5, no portal invasion, no nodal metastasis, or no distal metastasis based on the MRI and CCT, thorax, abdomen, pelvis. The baseline MRI abdomen showed segment 6 and 7, 7.1 into 7 into 6.2 centimeter lesion. And there was another lesion also in the segment 7, subcapsular measuring 0.8 into 0.7. And few, at least 4 to 5 arterial enhancing lesion are also seen in the segment 6 with no definitive washout. So, and the CCT, thorax, abdomen, pelvis didn't show any nodal or distant mets. So he underwent DEP test on December 2022. And at the first follow-up in March 2023, there were no clinical symptoms or signs. AFP decreased from 30,000 to 162. The MRI abdomen now showed a partial response in the form of decrease in the size to 6 into 6.6 into 8.6 centimeter with absent arterial enhancement and absent washout. And the previously seen segment 6 subcapsular and arterial enhancing lesions were not appreciated in the scan in March 2023. And the CCT tab again showed no nodal or distant metastasis. So this were the left side is the MRI and the right side is the CT. So on second follow-up, that is now in June 2023, there were no clinical symptoms or signs. AFP increased from 162 to 1037, and MRI abdomen, the previous lesion had decreased further in the form of 4.6 into 4.4 into 7.2 centimeters. But on the CECT TAP, there was a new onset 1.3 into 1.4 centimeter pulmonary nodule in the right lower lobe, which was suggestive of metastasis. And this is that pulmonary nodule in the right lower lobe, which is suggestive of a new onset metastasis. So he was started on systemic therapy. Since he was not affordable for immuno, he was started on lenvatinib 8 mg OD from June 2023. The adverse events which he had was grade 3 HFS after 3 cycles, and because of that, we had to withhold lenvatinib for 3 weeks. So first follow-up post lenvatinib in October 2023, there were no clinical symptoms or signs related to HCC, but his AFP had increased from 1037 to 3962. There was progression of disease on the CECT TAP. But the initial lesion of the liver, which underwent TACE, had showed further decrease in the form of 4.6 into 4.2 into 6.5. And but there was a new onset ill-defined tiny arterially phased hyperenhancing lesion in the segment 6 with washout on portal venous. And in the lung window, there were multiple, at least 6 in each lung, suspicious solid sub-centimeter size new onset pulmonary nodules. And he was started on second line systemic therapy now. So because he was a PSU bank manager, he had this credit facility available this time. And he would go on to get immunotherapy as his IO workup was within the normal limits. He was started on atezolizumab, bevacizumab from October 2023, but post cycle 2, his left medial malleus varicose ulcers kept on worsening. So we had to stop the bevacizumab and continue a single agent atezolizumab. So this is the first follow-up post atez-bev in January 2024. Now he had clinical symptoms in the form of dry cough and persistent left angle varicose ulcer. The AFP had increased from 3,000 to 15,000, and there was progression of the disease in the lung, while the post-stage liver lesion was still stable. So we gave him third line systemic therapy now in the form of cabozantinib 20-40 alternate day. So we could not escalate to more than this because of grade 3 HFS and post tolerance, as we had to make him skip at least 5 to 7 days of cabozantinib in each cycle. And also the non-healing right ankle ulcer was persisting, but not worsening now. So first follow-up post cabozantinib in May 2024 showed decrease in the AFP with no new symptoms. and there was partial response on the CCT-TAP with near complete resolution of the sub-centimeter lesions previously seen in the lung. Thank you.
Oh yeah, we're open to questions from.
So Anand, your comments first from your side. You said there are a lot of things to discuss. I honestly don't see much to discuss in terms of what was done. So your thoughts on the cases, and then we'll take the questions from everybody, and then we'll give our opinion as well.
Okay, so I think that if we had data for combining LDT and systemic therapy in 2022, probably this patient would have been a good candidate for that approach. We could have given him TKI or immuno, may have
Can I just interrupt and ask the surgeon, Sumana, would you agree with Anand, because 30,000 AFP, again, the traditional thinking has been any patient who has such a high AFP should never go for a transplant. Is that valid now, or if he responds to immuno, you would take him up for a transplant?
If we, at this point, if you ask me, I think if the AFP comes down and we give them enough time to see that there is no progression. But here, I think the way the things are, it is progressing. But maybe we will consider.
If it had responded, you would have taken for transplant.
If it had responded and it's given enough time,
you would have taken
therapy.
Okay.
We would.
Okay. Dr. Shaini is there from Max. I think he has left. Yeah, he is left. Okay. So Ahmedabad also, I think there's a liver transplant surgeon. Do you agree with Sumana that you can take immuno? Because that's the first point Anand is saying. If this was 2024, I would have given him both and then downstaged and taken for an LDLT.
No, I'm not going to LDLT or surgery at that point. Okay. What I was saying was something beyond only TACE for sure. And because I think in hindsight, this guy was not a good candidate because he rapidly progressed with lung mets despite a good initial local response. So in hindsight, it probably worked out. I mean, it didn't work out well for him, but we avoided something aggressive. But definitely systemic and at that time.
So Anand, can I ask you, would you, at this point, look at this fellow and say, okay, TACE followed by an adjuvant immuno, because that would have taken care of, because, till now the local lesion is under control. So your TACE has worked for the local lesion. It's the systemic that is relapsing each time, right?
Yeah. So I don't know whether we should call it adjuvant, but definitely systemic therapy for sure. And my question to the others is, if repeatedly the scans in the liver was showing response, and assuming he had a single lung met only, it didn't worsen this badly, would anyone think of doing something for the lung? Any thoughts?
Dr. Sujana, RT. SBRT to the lung. I mean, we are using SBRT right, left, and center for lung.
If you clearly categorize this patient as a oligo progression only and solitary oligo progression, then But again, like Dr. Anand was mentioning, AFP of 30,000 and it's behaving more like a systemic disease. So would this whole exercise be futile? Is my question.
So you would also say, let's give SBRT, but add the immuno or continue some system.
Definitely.
So I think Anand, that answers your question. Yeah. We would give. I mean, again, we are all happy giving SBRT to the lung, but I think we would add systemic. We would not give only SBRT. I think that answers your question.
Dr. Vamshi, Dr. Aditya
here
from Canara. So if only lung lesion is relapsing again and again, you can go for a repeat biopsy if possible to know what kind of, histopath is there. You will be surprised. There might be some other, malignancy in the underlying, and we might be just, over treating it with, or, without knowing what we are treating. If the patient is having, 2 or 3 times the relapse in the lung, I think better to do a biopsy as well.
Okay, I think that's a fair point, but only here you're temporally associated, and secondly, the AFP is going up each time. So I guess in this case, it's maybe not wondered, but point taken. Yeah. If you're having any discrepancy, your AFP is low and you're having new lesions, it makes sense.
Dr. Vamshi, I think I agree with what was said in the sense that if you have a single lung met and the primary is responding, in this case we got, AFP was going up, but I agree that it would be tempting to biopsy it before labeling it. I agree with that.
We have seen dual primaries. We are seeing dual primaries and dual lung.
And he was a smoker as well. So,
point well taken. Point well taken.
My question is, do you guys do biopsies in a situation like this when the AFP is so high with the CLD?
So again, I think that's $1 million question. We don't, in our setup, I think we don't biopsy more than 90% of cases. Viraj will disagree with me. Viraj wants to biopsy every case. So
we do biopsy all HCCs. And Anand, a very important question. This patient did not do well on other TKI and IO and did extremely well on carboplatin.
especially the biomarker response and disappearance of lung tumors. It just again brings back the question, if hypothetically we have done an NGS on this patient, would you think that there is something cooking here and there is a non-VEGF mechanism working at play here?
Anand, if you can take that.
To me, I think NGS in HCC is highly exploratory. I don't know whether I would have identified a marker. I don't know of a marker for that. So I really don't know. I think the immunoscore is just coming. I think I got lucky in that this patient did well on cabozantinib. I don't have a logical reason as to why he didn't do well on lenvatinib and it did well on cabo. I don't know.
Dr. Viraj, there was one patient, it was that becomes a very different case, but the patient was diagnosed to have HCC and family wanted to do everything. So I advised them, to go for the NGS. And I think that was the only 2 times which I have gone for the NGS. And you will be surprised that I got an EGFR exon 19 deletion on that biopsy report. And I was like, screaming on top of my lungs, should I go with this TKI or should I, really go with that TKI? So that was the biggest conundrum in HCC that I ever felt, the EGFR mutation. And when I read the paper, there are papers showing that the EGFR mutation is to the tunes of 11 to 20%. And we don't have any data to give them, anti-EGFR therapies.
I think the mutational profiles in HCC are all over the place because the Southeast Asian data simply does not match with the North American data. And they have these single mutations, as you said, 15, 20, 25%. So it's actually a little tempting. These small series have these mutational data, but I don't know. Maybe Viraj, you could shed some.
I think the other challenge is, what do you give it? I mean, which mutation will you say, okay, I'll give lenvatinib and not give cabo, or the vice versa? Unless you are specifically looking at a MET or something, which is again not the right target for a cabo. So
the MET or a DEL 19, as was said, I would just go with that on faith. I don't know whether that's the right answer, but that's what I would do.
We don't even know if this is a driver.
Yeah.
Again, the commonest is actually a TP53, which doesn't help us much.
Yeah, which is just a dead end.
Yeah.
Dr. Vamshi, the point I was making is subsequent lines benefit from TKI usually happens when the primary TKI has worked well. Usually that is how it goes. Sora does well, Lenva does well, Cabo does well. And why I brought NGS is we know there are MET alterations, MET amplifications and fusions are found in HCCs. And we know Len is not a good anti-MET and Cabo is. And because such a good response on Cabo with no response on lenvatinib, again boils down to the question that we should be doing more and more NGS, especially in Tata, especially as part of research.
Yeah, agreed. We should be. In fact, I think the Rego trial had an inclusion that you had to have some degree of response to sorafenib before you could take. So fair point.
So we all are sitting together, we can just formulate the strategy of going ahead with the research proposal from all the big centers.
No, you should write it and we'll all follow it. I can tell you this is the standard answer which TMH people tell me, and I completely agree with them. Writing a proposal, a multi-centric, and getting 5 centers to sign on is, I know you can see Prabhat laughing. It is a big job, but if you do it, I think we'll all be happy to collaborate with you because we are getting tissues and we are getting tests availability. So, please go ahead and we'll all join you in that. But you're right, we need this data from India. So any other comment? I think there's nothing much else to comment. So Anant, if you can take that last final question of viral versus non-viral, and we are never going to have a right answer, but just your thoughts, and then I think we can close it. It's 9, so I think we are in good time. We can close it.
I'm not going to base my data yet or treatment yet based on whether you're viral, non-viral, or non-NASH, non-NASH. The data to me is not strong enough. I'm not sure it will come. So since numerically, most of the IO drugs are doing better than TKI, I would consider IO still as first line, and you can take your pick of what combination.
So thank you. Thanks to all these centers for participating very enthusiastically. I hope the people who have been listening have learned. Again, my final point is very simple. Go with an MDT. Make sure you get all the stakeholders involved. They may be able to offer you a solution that you have not thought of. And that is very important because we all have prejudices. We all have prior thoughts as to what works, what doesn't. It's only when you talk to others that you learn that there are other modalities available, and ultimately the patient benefits from all of that. So thanks to AstraZeneca for helping us this. Viraj, over to you for your final comments, and then we can close the session.
No, I think so. We had a wonderful discussion for last 2 hours, starting from early transplants and ending up with systemic therapy. Thank you, AstraZeneca, for giving us this opportunity. And I'll hand over to AstraZeneca back to end the session for today.
Okay, last comment. Last comment after all the last comments, Dr. Sumna.
Have been done has to be clearly explained, especially when it comes to transplant. The recurrence rate, everything needs to be explained. With the decision of doing something like that.
Perfect. Point well made. Again, MDT matters. I will request Dr. Basade sir to give the final closing remarks, and then we can close. And for those who have started dinner, continue dinner. For those who haven't, please, let's all go have dinner. Dr. Basade sir.
Thank you, Vamshi and Viraj, for conducting such a wonderful symposia. And I really learned a lot during whole 2.5 hours of session, and hope that you all people cooperate with future our endeavors from the ISMPO. We will get support from the industry as well. And this was really wonderful, and this was the first from the AstraZeneca. So there are 2 more lined up for the such kind of meetings, and I think we really enjoyed it. So thank you very much from ISMPU to everybody, and thanks AstraZeneca for having such a wonderful session. Thank you. Take care.
Thank you.
Good night, everyone.